Welcome back. We shall start our next case presentation of a redo case. It will be presented by Dr. Siddharth V. Singh, Dr. Saurabh Tripathi, and Dr. Avnindra Tripathi from SGPJ Lucknow. To chair this, we have Dr. V Bashi, Dr. C.S. Hiremath, and Dr. Anil Tendolkar, sir. And Dr. Prasanna, sir, to chair the next session.
Good afternoon, sir. I shall be presenting the history and the examination part of this case.
From next time, it should not be one hospital doing it.
Oh.
I want different hospitals to mix and match.
Okay, sir. So I'm presenting the case of Lakshmi, a 46-year-old lady, housewife, literate, resident of Bangalore, who presented to this institute with the chief complaints of breathlessness on exertion for 6 months and chest pain on exertion for 6 months. According to the patient, she was apparently well 6 months back when she developed complaints of breathlessness on exertion, which was insidious in onset, non-progressive, occurred on walking about 500 meters in fast pace or climbing one flight of stairs.
Say that this thing was NYHA class.
NYHA class 2. Yes, sir. Okay, sir. Yes, sir. Great. Yes, sir. The breathlessness was associated with occasional palpitations and there were no other associated symptoms. The patient also complains of dull aching pain on the chest on the left side on exertion for the past 6 months, which occurred on much about the same activity as for breathlessness and was relieved after 15 to 20 minutes of taking rest. That was class 2. And for past 15 days, the patient is having complaints of constant dull aching pain on the left side of the chest, radiating to the left arm and hand, even while she's resting and during sleep. There is no history of any cough, expectoration, hemoptysis, palpitations, dizziness, syncope, or history suggestive of any orthopnea or PND. There is no history of any loss of consciousness, blurring of vision, slurring of speech, suggestive of any cerebral embolic phenomena. There is no history of sudden severe pain in the limbs with blackening of digits or foot, suggestive of limb ischemia or embolic phenomena. There is no history of any anorexia, nausea, vomiting, pedal edema, suggestive of failure symptoms. There is no history of any change in quality of voice or dysphagia, suggestive of pressure symptoms. There is no history of any prolonged fever, joint pain, skin lesions of fingers or toes, suggestive of any endocarditis episodes. And there is no history of any recurrent episodes of respiratory tract infections in the childhood or cyanosis in the childhood. Coming to the past history, there is the patient who underwent a balloon mitral valvotomy in the year 1998. Sir?
I have to ask you one question.
Yes, sir.
It's a continuum of a case, right?
Yes, sir.
So now you are telling me about what happened in childhood. But the most important thing in this case is, I presume this is a redo case.
Redo case, sir.
So a patient who is known to have this surgery has now come to the way it should go about.
Okay, sir.
Not this became a past history. This is very much relevant to the
present history.
So you should change the entire pattern of presentation.
Okay, sir.
After complaints of dyspnea,
Yes, sir.
it will start with patient underwent a presumed balloon mitral valvotomy in 1995,
Yes, sir.
was fine for so many years,
Yes, sir.
was taking these medicines, taking the prophylaxis,
Yes,
and now has
No,
this.
and has had a
This is
cardiac
a
surgery,
repeated mistake by all the students. Same operation, same disease. They try to show it as some
Past.
past.
It is a continuum. No, patient has had a balloon valvotomy, has had cardiac surgery, and is now.
Dr. Bashi, you agree or disagree?
100% agree. 100%.
Thank you.
No, okay.
And you are telling me cyanosis in childhood. That is okay. But
Yes,
operation done 10 years back is not. So please, unless it is hysterectomy or tubectomy, I can understand that. But this is the same disease. Try to paint a picture in the minds of the people to whom you are narrating.
Okay.
So can you refurnish
Yes, sir.
again?
So the patient had complaints of breathlessness for 6 months and chest pain for 6 months, which was continuous for past 15 days. And the patient also had an episode, had a history of BMV done in 1998, balloon mitral valvotomy, and thereafter she underwent an open heart surgery, which was an open. So she underwent an aortic valve replacement with open mitral commissurotomy in the year 2012. Yes, sir. Yes, sir.
Balloon valve. First a balloon valvotomy, then
balloon valve,
a AVR OMV.
Yes, sir. And she had been fined for the. Yes, sir. She had been doing well for the past 12 years when her complaint started 6 months back.
Last 12 years, is she compliant with all the medical treatment
Yes, sir.
that was prescribed to her?
Yes, sir.
Particularly anticoagulation if she was prescribed.
Yes, sir.
Rheumatic prophylaxis.
Yes. So she was taking tablet aspirin.
You can start also like this patient who the patient who I'm presenting has already undergone a valvotomy and open heart surgery in such and such an year, has presented now with such and such symptom. That is maybe another way of presentation. I don't others agree for that, or I don't know.
Yeah,
How
that's the way it should.
Okay, sir.
How old?
Sir,
How old?
the patient is 49, sir.
Okay, go ahead. Go ahead.
Yes, sir. Sir, the post-operative period of the patient was uneventful and she was discharged on the 7th day post-surgery. And she had some serious discharge from the wound after 7 days. And after 6 months of surgery, she underwent some injectable treatment at the local site of.
He just say that she had a keloid scar and was just saying, don't make, do you want to have more questions on that? No.
So there is no history suggestive of any sore throat, joint pain, or long-standing fever in her childhood. The patient has also underwent total abdominal hysterectomy in the year 2012. Yes, sir.
What percentage of patients give history of rheumatic fever? Those patients who present with rheumatic heart disease, how many percentage of the patients will give a history of rheumatic fever?
So 15 to 20%.
Correct, huh? Where
He's
did you get that?
15 to 20%. Okay.
Okay.
In India, not many people actually have the full
Yes, sir.
blown Duckett-Jones criteria. It was actually very few of them, and most of them have arthralgia rather than classic arthritis.
Okay.
So there is no significant contributory family history. She is married with 2 children, and there is no history of any similar illness in any of the family members. In the treatment history, the patient, sir. Sir, they are both twins and 22 years of age. Yes, sir.
Her categorically,
Yes, sir.
does she feel she means
Family.
she and her partner feels that they are finished family.
Yes, sir.
Okay, it's important.
Yes.
This is 22-year-old and 2 sons. So
2 daughters, sir.
2 daughters, my God, then they might not have finished. Just remember, I'm not joking. I'm very, very practical about it, serious about it. So it is mandatory because your entire plan of action, she's 49.
49.
She's premenopausal. Am I
Sir,
right?
she already underwent TH, total abdominal hysterectomy.
Okay. Hysterectomy. सवाल ही नहीं.
Yes, sir.
Okay, excellent.
So in the treatment history, she is currently on tablet furosemide 40 mg once daily and tablet spironolactone 25 mg once daily and tablet aspirin 75 mg once daily and tablet metoprolol 25 mg once daily. In the personal history.
So now, based on this, what operation was done? What prosthesis was used? Had she been advised anticoagulation? Or
No, sir. She was suffering from dysfunctional uterine bleeding at the time of surgery. So she couldn't be prescribed warfarin or acetrom. So she underwent bioprosthesis implantation that time.
If you know that information, please offer it straight away.
Okay, sir. And sir, there is no significant contributory personal history. Sir, my diagnosis is recurrent post BMV. Sir, it's a case. The possibility is either restenosis after commissurotomy.
Either
Mitral restenosis.
Yes, sir. or
Why?
it could be
Why you thought it first?
because there are the results of
She complaints of
breathlessness.
dyspnea
Yes, sir.
as the first complaint.
Yes, sir.
Okay.
Yes.
Second possibility,
It could be, sir, aortic.
what could be in addition,
In addition.
plus minus.
Yes, sir. Aortic valve pathology.
Why
What
you think of
pathology?
So aortic stenosis.
Aortic valve, prosthetic degeneration.
degeneration?
Yes, sir.
So why you think of prosthetic degeneration?
So it's been 12 years after the implantation,
Okay.
and she has symptoms of angina pointing towards aortic valve disease.
Two,
And
did she have any pregnancy during that 12
No,
years?
sir.
No.
I want to ask if you have angina
Yes, sir.
in a patient who has had an aortic valve replacement and she is still, I mean, technically in premenopausal lady, though I don't know whether her ovaries have been removed,
Yes, sir.
but in this sort of case, what do you think and plan in your mind? Patient has had a AVR and has had maybe a biprosthetic valve, whatever, it's smooth,
Yes, sir.
but she's having angina, premenopausal lady developing angina.
So aortic valve disease or concomitant coronary artery disease.
What specific coronary artery disease in a premenopausal lady, we'll assume her ovaries are intact,
Yes, sir.
would she get? What are the chance of a lady getting coronary artery? Not that she can't, but in specific relation to aortic valve surgery,
Yes, sir.
what would you think of?
Sir,
Prasanna is trying to tell you
Yes, sir.
she is 49-year-old. Her ovaries are preserved. She is unlikely to be premenopausal. So there are any other non-atherosclerotic causes.
sir,
of
it could be
angina.
anomalous coronary arteries that could
Sorry?
Al-Kappa syndrome, like
Alkapa, you mean to
sorry.
say that two
Alkapa
surgeries
not
have been done?
operated at the
No, she
time
was-
of first
Okay, then
surgery.
that is self-goal.
Sir, sorry, sir.
Which is
This is your fourth or fifth attempt of that snake and ladder, entering the snake and reaching zero.
head dive.
So it could be
Sir is laughing. I can hear his laughter from Chennai.
so coronary artery disease could be there. Associated.
Coronary artery disease, I'm saying she's premenopausal. Very
Okay, Prasanna.
okay.
What type of
Coronary artery disease.
after AVR?
Yeah, that is what I'm trying to ask.
Anybody else? You two, TWO and TOO, both. Anybody else? Osteal
Speak into the mic.
because of
Why?
syphilitic arteritis. Nahi. Then?
No.
Nahi.
So what is it?
The
Why did you?
osteal cardioplegia injures the endothelium. Yesterday, I think sir only told that if you try to push in a large size cannula, may dissect. So we reuse the cannulae, all produce endothelial injury, and patient can develop osteal stenosis. And much below the line, the strut, of course, strut problems she should have had immediately or earlier. But just keep all this in mind. Okay?
And
He's again trying to tell you, 49-year-old, don't try to jump to coronary artery disease. Classic atherosclerotic.
The other
There
thing,
could be other causes.
yeah, and then again, if let us assume that she has not had anticoagulation all these years, not requiring it, the other option would have been a homograft. And when you put a homograft in and when you sew around the coronaries, that also could have crumpled down. Okay. All these are possibilities.
So shall I proceed
Yeah.
with the examination?
Theory
It won't-
gully mein chali.
It won't be totally wrong. Means I don't mind planning where she underwent surgery.
Surgery.
So
Because in the previous discussion, Dr. Sampath Kumar, Prasanna were telling at this institution,
At this
at that institution, in Delhi. So certain surgeries are feasible in particular
Places.
institutions.
so she underwent the previous surgeries at St. John's, Bangalore.
Okay.
St. John's Hospital.
Yeah, fine. Because see, 15 years back, I used to implant lot of homografts.
Oops.
Like that. So Dr. Sampath Kumar means you'll start thinking, oh, that surgeon was doing these operations. Okay.
Another aspect of year of surgery was the type of cardioplegia.
Cardioplegia.
It's another aspect which tells you Nowadays, it has become almost standardized. But prior to say 1980s, it was almost trial and error. Every day our cardioplegia is to change. And we used to make homemade. Morning, every day morning, a different recipe of cardioplegia. So cardioplegia was total infancy that time. Now it is almost standardized. So year of surgery, place of surgery also tell you lots of things about.
And also the kind of tissue valve that was available at that time.
So this is important. Of course, you must know history of cardiac surgery in India from this point of view.
Okay, sir.
Okay. Have you seen the patient's operation notes?
No, so I couldn't find.
Suppose I tell you I have got operation notes of the patient. What you will like to ask me about
Or
the
read.
operation notes? All of you can try. Huh?
What do you see?
Not only one thing, several things you want to ask.
All in the operation note, what would you like to see?
So
Just for your knowledge, I conduct one program called Difficult Coronary Anastomosis. On redo coronary anastomosis, Dr. Yugal Mishra discussed for 1 hour the information in operation notes of a coronary. Okay, so if not 1 hour, at least 10 minutes, ask.
What would you like to know?
So
And that also highlights the importance when you do an operation to write the operation notes meticulously so that a person doing the second operation will find it very easy and patient will be safe. So one very important point you should always remember, immediately after the operation, write all the finer details the same day itself before you go home.
Okay, start telling.
So the mode of cardioplegia, was it root cardioplegia or
First of all, bypass.
bypass?
Okay, peripheral cannulation, you need not bother.
Yes, sir.
Surgeon will, the examiner will see the scar. But here you will like to know it was a bicable or single cable.
Single.
This is AVR OMC, so it is obviously
Could be single.
bicable,
Bicable.
Yes.
not two stage. But you will like to know whether SVC was directly cannulated or RA appendage
Appendage
was cannulated. Number 2, cardioplegia.
Yes, sir.
Type of cardioplegia. 3, approach to mitral
Mitral valve.
valve.
Yes, sir.
How did they approach? Paraseptal or
Transect.
transseptal? Okay.
Yes, sir.
Aortic valve. What valve? What suture?
Yes, sir.
What is
Fetched, no
what
fetched.
dangerous suturing is for second time suturing? Second time redo? What type of suturing is dangerous? You pray your enemy also should not have.
So continuous.
No. Continuous, I cut the thread and it will come out.
It's non-everting mattress.
Okay.
Where the plagets are
Pledges in
on
LV
the
side.
LV side.
Yes, sir.
So fortunately, hopefully, 12 years later, all plagets are endothelialized, fibrous, etc. But if you do a little early, what can happen? One plaget may fall down.
Yes, sir.
Where? Down where?
LV cavity.
LV cavity. And you won't be able to see it.
Trace, yes.
Understand?
Yes.
So each and every aspect should be noted and recorded. And what is the last one?
So the number of sutures taken.
On the aorta.
Aorta.
Next.
Um,
How did the patient come off? Well or not, did not
Yes.
well?
And-
Then you told me got discharged on 7th
Seventh
day.
day, yes,
So
sir.
must be very smooth.
Yes, sir.
Correct?
Yes, sir.
Anything about operation notes? Last part.
Yeah, very important part,
important.
the last.
If you are opening the sternum,
So what was the mode of closing the sternum? What wires were used? Was
that will see X-ray.
yes, sir.
Before wire.
Everybody.
Pericardium was closed or not?
Yeah, very good.
In our drama,
Yes, sir.
the prompting should be heard by the actor. Here the whole crowd is hearing, but the actor not hearing. Post lunch. Huh?
Which can make the sternotomy safer or dangerous.
Pericardial closure would
The
make it-
pericardium has been
So
closed.
how the pericardium has been closed.
Yes.
Okay. And plus the kind of pathology. Was it for aortic stenosis,
or
calcific aortic valve? That time, what did they do to that calcium?
yes, sir.
That is not going to disappear. Something which is not removed.
Whether the pleura was opened,
The
whether the
condition
pleural
of the
tube was
mitral
formed.
valve when OMV was done.
Yes, sir.
What was subvalvular fusion and all the other things when they did a OMV?
Yes, sir.
Because that's maybe the reason why it has restenosed again.
Dr. Bashi is telling you that the pleura was opened.
Yes, sir.
Which pleura will be opened?
Right sided, sir.
Very good. So you must know
Yes, sir.
the right lung may overexpand
Yes, sir.
and cross.
Midline. Yes, sir.
So remember
I
so
see.
many things in the operation notes. So all this you can jot down before presenting the case. And all this you will like to know. How many drains were put?
What
Sir,
ICDs?
I couldn't.
Was spacing required?
Pacing wire, whether it was removed.
Remove
See,
or
some people
flush.
just flush and
Flush.
cut, and that is a nasty thing to happen.
Okay. Last thing, protein reaction, whether they are written there.
Yes, sir.
And any problem in perioperative problems with the patient had,
About intubation,
intubation,
difficult intubation, everything. So there are so many things to know about. All that we write, AVR OMC done with BS valve, this date, bus signature. That is the operation,
Yeah.
longest operation notes I have seen. Okay, we have Shelly one. Okay, sorry.
Sir, coming to the examination, I examined the patient in a well-lit room in semi-recumbent and sitting position with adequate exposure and proper consent in the presence of a female doctor colleague. At the time of examination, she was well oriented to time, place, and person, and conscious, comfortable, and cooperative. She has a height of 155 centimeter and a weight of 69 kg with a BMI of 28.7 kg per meter square and a BSA of 1.72. She is
1.72 with what?
me-
What is the height?
sir, 155 centimeter.
No, because telling 1.72.
So there is no pallor, icterus. So there is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. On vitals examination, temperature was normal. Pulse rate was 76 per minute, regular, low volume pulse, no radial or radiofemoral delay, and the condition of the arterial wall was normal.
So what does it tell you? Regular pulse.
Yes, sir.
So what is unlikely?
AF.
AF
Yes, sir.
or intermittent AF
Yes, sir.
possible.
Yes, sir.
So mitral valve disease unlikely.
Unlikely, sir.
Number two,
It's
pulse
a slow
volume,
rising pulse, low
pulse
volume,
volume.
low volume, slow rising pulse, sir.
So pulses tardus are
Opposite third.
parvus.
Yes, sir.
Parvus means what?
Feet.
Low volume.
Okay,
And
sir.
tardus means slow,
Slow, yes, sir.
tardy, slowly rising. So what are you trying to suggest?
Sir, it could be aortic.
Not could be, or
Look,
it is.
It is an aortic stenosis.
These are not court of lawyer.
Okay, sir.
It is
Okay, sir.
bioprosthetic dysfunction resulting in aortic stenosis. And there could be an additional
Mitral
moderate
pulse.
mitral stenosis.
Yes.
So two stenotic lesions
Yes.
giving rise to this pulsus tardus are parvus.
Okay.
Okay.
Sir, blood pressure is 106 by 68 millimeters of
So
mercury.
what does it tell you? 106 by 68.
There is no regurgitant lesion.
Unlikely a dominant aortic regurgitation.
Yes.
तुम अरिगर्जिटेंट लीजन मत बोल बेटा.
Okay, sir. Aortic regurgitation.
More you bull's eye you hit, more marks you get.
Yes, sir.
Have you noticed irritability increasing?
Yes.
So what is going to happen to your marks? Inversely proportional.
Yes.
Okay.
So respiratory rate is 20 per minute. Saturation is 96% on room air, and JVP is not raised.
So what do you think? 96%.
Okay, sir. Normal for this.
So aren't you surprised? A lady with such a long-standing
Yes, sir.
mitral valve disease seems to be having
Normal.
pretty good lungs.
Yes, sir.
Okay. What kind of lung disease they are notorious to have? Long-standing mitral valve disease with an additional scar on the thorax.
Sir, restrictive lung disease.
Thank you. Good boy. ऐसा भी ना स्पेसिफिक बात कर यार. तुझे लखनऊ जाना है, मुझे मुंबई जाना है.
Coming to cardiovascular system examination, on inspection, the shape of the chest is normal, bilaterally symmetrical with transverse diameter more than anterior-posterior diameter. A keloid of size 15 by 4 centimeter is present over.
There is a scar.
Yes, sir.
पहला scar बोलो, then keloid.
Yes, sir. A scar of size 15 by 4
अरे
centimeters.
median sternotomy scar.
Yes, sir. Is present over the site of previous surgical median sternotomy with 2 additional scars.
Suppose operation notes were not known to you.
Yes, sir.
What is the possibility? Median sternotomy scar, 49-year-old complaining dyspnea. These are the standard questions asked.
sir.
Huh?
So,
बाकी लखनऊ के नवाब जरा साहिबजादों को मदद करो.
sir, it could be
Could be a congenital heart disease like
congenital heart disease with
ASD.
Yes,
So
sir.
why she is not having dyspnea? LV dysfunction.
Yes, sir.
Okay.
Yes.
Additional valvular affection.
Okay.
Second possibility.
Could be she could have undergone a shunt procedure, central shunt probably.
But now you said pink, no? 95% saturation.
That is what, sir.
Central shunt.
So again you have come down. Oh, सांप सीढ़ी का खेल में
Yes.
जीरो पर आ गया.
Yes.
-0, कलस, खाई में गिर गए. Then constrictive pericarditis operation.
Yes, sir.
She said 12 years back then.
Yes, sir.
She doesn't know. हमार को का मालूम how. So constrictive pericarditis. So just keep your mind open.
Okay.
Don't say coronary CABG.
Okay.
Okay. 12 years back. Coming back. So scar shows keloid.
Keloid formation and there
Now
are 2 additional scars.
ask difference between keloid and hypertrophic scar. I don't know.
So,
But you're supposed to know.
so hypertrophic scar extends to the extent of the hypertrophic scar is confined to the incision line, but keloid extends well beyond the incision line.
Excellent.
And it is itchy and sometimes tender.
Excellent.
And so there are 2 additional scars at previous drain sites.
Where are they?
Sir, and in the epigastrium.
Thank you.
Yes.
Suppose they were in the intercostal space.
Sir, sorry, sir.
Suppose those drain scars were in the intercostal space, in the
Yes, sir.
anterior axillary line,
Yes, sir.
in the 5th space, what it would have meant.
It would have meant post-operative pleural effusion or pleura was opened probably.
Thank you.
Thank you. So what does it mean to you as a surgeon?
Adhesions could be.
Lung adhesions
Yes,
would
sir.
be there.
Yes, sir.
So we'll come during the redo.
Bashi sir is writing notes, sir.
Hmm.
He's going to ask big question. Sir, you can ask right now. It will be much fresh and better.
Yeah. Now, I mean, what is, you are reached up to the scar state only now. What is next?
Sir, I could not appreciate a visible apical impulse.
Okay.
And I will prefer you to say no other scars present.
Sir, I have to said it in the other sentence.
Afterwards, you are going
Yes,
to say.
yes, sir.
Okay.
So there are no other scars, dilated veins, sinuses or
So
visible
which
pulsation.
scar, other scars?
Any other, sir, previous?
Like what? See,
Sir-
you say something and now you have started thinking.
Sir, could have been closed mitral procedure done before.
Okay.
She's not giving the history
No,
of.
no, related to that open heart only.
Yes, sir.
I actually want to know because she has another scar. I'm telling you, she has another scar.
Sir, abdominal hysterectomy scar.
Ah.
Tell me what is the relation between the abdominal hysterectomy scar and relevance to a redo now? What type of scar is it? Fan and steel?
Fancy, sir.
Now, all the more with the fan and steel incision, what challenge you face?
So we may have adhesions at the site of the groin, which may make peripheral cannulation difficult for us.
Yeah.
Thank you. So you also look for any peripheral cannulation scars.
Yes, sir.
12 years back,
Mhm.
cannulation technology was in childhood, infancy. We used to do open cannulation.
Yes.
Okay? Chalo.
Sir, on palpation, the temperature is normal over the chest. Scar is non-tender to touch.
Temperature is normal over the chest.
Over the precordium, sir.
Temperature over the precordium. My God.
Sir, inflamed scar. I've
Sir
tried
is
to-
laughing.
They say scar, the keloid scar does not have
Active inflammation. Yes. Yes. Okay.
There is no sinuses.
Yes.
First, finish it.
Okay, sir.
Healthy scar.
Okay, sir. So the apex beat is situated in the left 5th intercostal space in the mid-clavicular line and
So,
heaving type of
so
apex.
apex scene. So this is inspection, no?
No, sir. Coming to palpation.
Inspection हो गया?
Yes, sir.
हमने सुना च नहीं.
Sir,
The scar sinuses, all that is not.
But that we heard, but Precordial inspection?
So I've told no, there was no visible apical impulse and there are no other
So
pulsations.
no visible impulse means what?
So she is a healthy lady.
No
Yes, sir.
visible impulse or the precordial.
Visible impulse.
On the precordial,
Yes, sir. So there's no
no pulmonary
Hypertension.
hypertension or AR likely to be
unlikely, sir.
unlikely.
Yes, sir.
You have seen
Yes, sir.
suprasternal pulsations.
Pulsations also.
Okay.
Yes, sir.
Now confirmation on palpation.
Yes, sir.
This means what? 2 minutes. Over. Okay. Half line.
Yes, sir. So apex PT is situated in the left fifth intercostal space in mid-clavicular line,
So what
And
does it
receiving-
mean? Heart is
not enlarged.
Heart is
no,
not
no
enlarged.
cardiomegaly, sir.
okay.
Yes, sir. There is no parasternal heave.
Are you surprised? Not surprised?
No, sir.
Why?
It goes with the history of the patient.
What that?
That she is giving history of
Is
angina
a patient of AS with
Yes, sir.
plus minus
minus mitral
MS
stenosis.
unlikely to have large
Heart,
heart.
sir. Yes,
It's
sir.
a bad sign.
Yes, sir.
Large heart.
So there is no parasternal heave and there is no thrill palpable. Coming to percussion, on percussion, liver dullness is present in the right fifth intercostal space.
Okay, accept small heart.
Yes, sir.
Auscultation.
Sir, on auscultation, S1 was normal. S2 is
Not was. She's alive.
S1 normal.
It's normal.
Yes, sir. S1 is normal. S2 is single. I could not appreciate. And a grade 3/6 ejection systolic murmur.
Please don't try to be Raja Harish Chandra.
Okay, sir.
You know Raja Harish Chandra? He always spoke the truth.
Yes, sir.
So if you say single S2, unnecessarily you will run into trouble. Okay? So don't say single S2.
Sir, a grade 3/6 ejection systolic murmur is heard in the right second intercostal space, radiating to carotids.
In the morning we discuss
Yes,
the
sir.
importance of right second space.
Yes, sir.
That means the aorta is
Valvular pathology. Yes,
dilated.
yes, sir.
Okay?
Yes, sir.
So what size valve must have gone in?
Uh,
That, by the way, in operation notes,
yes, sir.
there's another thing you must know.
Yes, sir.
What is the size of
Size
the
of the
valve?
valve. Yes, sir.
So most probably 23, 25,
Okay, sir.
but unlikely in a patient of AS with MS.
Yes, sir. The murmur is heard best with the diaphragm of the stethoscope in the patient leaning forward position at the peak of expiration. Another grade 2/4 mid-diastolic murmur heard in the apex, best heard with the bell of stethoscope in left lateral position at the peak of expiration.
DD of that murmur?
Sir, some stenotic, mitral stenotic murmur.
DD. One is mitral stenosis.
Yes, sir.
Anything else? Differential diagnosis of that murmur.
Yes, sir.
What is that other possibility of that murmur?
Sir, diastolic murmur could be because of AR also. Not
No,
exact,
no.
not
Heard at the apex. What is Austin Flint murmur?
Yes, sir.
Austin Flint murmur?
You
Heard
already
it?
said answer.
Patient with AR,
AR, yes, sir.
the AML is pushed
Collapse,
down
yes, sir.
and you may get an Austin Flint murmur.
Okay, sir.
Classically 2/4, no opening snap,
Yes, sir.
no presystolic accentuation.
Okay.
All things are possible.
That is an early diastolic murmur, Austin Flint murmur.
Yes, sir.
Whereas mitral stenosis is a organic mitral stenosis is a mid-diastolic murmur. There is a difference between Austin Flint and mitral stenotic murmur. Early diastolic always is an Austin Flint murmur. I mean, of course, we don't have to know too much about the finer details. I'm just telling. Okay.
So there are no other murmurs audible.
Okay.
Yes, sir. So rest of the systemic examination is essentially normal.
So,
So-
diagnosis,
So on the basis of my history and examination, my diagnosis is it's an acquired valvular heart disease, most probably a rheumatic mitral stenosis with aortic stenosis. Status post.
I
Aortic,
will accept even
Hmm.
straight away saying rheumatic heart disease.
Okay.
Tell me one etiology which affects young patient, affects mitral valve, affects mitral and aortic valve. Which etiology? Only rheumatic.
Rheumatic, yes, sir.
So why most probably?
Okay.
It is rheumatic.
Can you quantify aortic stenosis?
Sorry, sir.
Dr. Srikrishna feels you must say mitral restenosis.
Okay.
And
What is the
then
difference between mitral stenosis and restenosis?
The patient has underwent a previous procedure.
More chance of having calcification,
Calcifications, yes.
small annulus, subvalvular fusion.
Subvalvular pathology.
Okay.
Yes.
You said aortic stenosis. Can you qualify that?
Yes, sir.
What do you say?
So on the basis of history, the patient has complaints of breathlessness and angina.
No.
Quantify.
Quantify.
Mild, moderate, severe.
So the patient is symptomatic, so probably a severe stenosis.
And you call it prosthetic stenosis, this is not a primary aortic stenosis.
Yes, sir.
You have to say prosthetic stenosis.
Prosthetic stenosis.
Prosthetic aortic valve stenosis. That is what you should say.
Okay, sir.
Mitral restenosis and prosthetic aortic valve stenosis. Okay.
Okay, sir.
And you tried your best to hear aortic regurgitation.
Yes, sir.
And you have to tell all the maneuvers you did to hear the regurgitation. Okay.
So she is in normal sinus rhythm, NYHA class 2 on treatment with no signs of congestive heart failure or infective endocarditis.
PH you forgot.
PH also, sir. Yes. No signs of pulmonary artery hypertension, congestive heart failure or infective endocarditis.
Okay. Excellent. Chalo. X-ray. X-ray. What are you expecting to see X-ray? Who is going to speak? Who is going to speak? Don't put up the X-ray. Tell me, what are you expecting to see?
Sir, we'll be expecting LV type apex on the X-ray with a cardiothoracic ratio of 0.5.
Go ahead.
And
There are 25 more things to be told.
Sternal wires and studs of the bioprosthetic valve.
Mitral restenosis, yes or no? I asked him why this is not functional mitral stenosis. So you like to see features of mitral stenosis,
Mitral stenosis.
LA enlargement, pulmonary venous congestion. Okay. Now with this, aided with that, check C.
So the cardiothoracic ratio is 0.5. And the apex is LV type.
See, you'll miss the format of presenting X-ray. This is 4th or 5th time we are reading X-ray. CT ratio, right heart border, left heart border, starting from top, going to base. You never talk about apex straight away.
Sir, CT ratio of 0.5. Right heart border is normal, sir. The left,
It is beyond the vertebra.
it is
So it
beyond the
not
vertebra.
normal. It is enlarged. But you are not able to tell whether it is LA or RA.
RA.
What about the upper right heart border? Right heart border divided into two. Upper half, lower half. Upper half formed by loudly
SVC,
SVC and
aorta,
ascending aorta.
ascending aorta.
So it is prominent. Surprise, not surprise. Not surprise. Okay.
Other thing that
Yes, sir.
see from this side, any bump or lump which should be there is missing.
What bump and lump?
Heart border.
Yes, sir.
What
On the left,
happened to the left heart border?
sir, straightening of the left heart border is
Very good.
When you say straight, I want in this patient, you should not be saying straight. There is something specific you are going to search for. In this case.
What is that?
What is of the LA appendage? What have they done for the LA appendage? Have they ligated it? See here, having the aortic knuckle MPA, can you see?
You can see the moguls. This is called moguls. Knuckle, MPA, LA. Can see the knuckle called moguls. Okay.
The LA appendage there.
Then important
LA appendage followed by the
ventricle.
ventricle. LV.
What about anything else you will report?
Something else is there. Very important.
I can see something over
can
there, but
see
not
there.
very sure.
No, it is there, sir.
Are
Signs of
bioprosthetic valve, na?
bioprosthetic valve.
It
Yes,
is
sir.
there.
So
Studs of the bioprosthetic valve.
why strut the swing ring also? The ring also can be
It is
seen.
there.
Yes.
See, it is
Swing
well
ring.
seen in the lateral X-ray especially.
Yes.
Why the lateral X-ray has been taken?
Sir,
First
because
time in my lifetime I'm seeing.
sir, because she was already operated once,
So-
so we'll have to assess the retrosternal space
So,
because after
so assess and tell.
What do you think about the retrosternal space?
Quick. Before
It's not obliterated, sir. It
you
looks
can see a nice radiolucency,
Upper
sir.
part, there is a good radial lucency, but the
but
last
lower
wire,
part,
lower
last
part
wire-
is, yes.
uh,
Last two wires, it is, the
Okay.
sternum is adhered to the underlying heart.
excellent. Are you able to see the prosthesis in the lateral view?
Yes, sir.
Where is it?
yeah, and what is it? Is it aortic prosthesis, mitral prosthesis?
Any signature sign of the prosthesis? Any typical shape, size? So you expect 4 studs to see or 2 studs? So bioprosthesis.
It's a bioprosthesis. And is it aortic or mitral?
Same thing, you'll draw a line in the lateral view.
In the lateral view,
Lateral view, draw a line from the anterior sternophrenic angle to the end hole of the bronchus. Okay? See that endole scene, endole shadow of the bronchus? See that?
Yeah.
So that is the
Is it
line.
above?
Above that, aortic. Below that, mitral. Okay? So
it
it's
is-
above. Any calcification, etc., ascending aorta, nothing. Okay? ECG. Now tell me the ECG findings. No, don't look there.
Yes, sir.
Tell.
Sir, sinus rhythm, because the pulse was regular. So the rate was 75 per minute.
Accept everything.
Sinus.
Chalo. Go ahead.
Axis of 50 degrees, sir.
Why?
Sir, because in we check the axis in
You
the,
have seen the ECG already.
yes.
And you are seeing 50
Also.
degrees. Sida. I'm telling you, trying to picturize from
Predict.
clinical and X-ray. तुम क्या होशियार बन गया यार?
Predict it. See, you have to predict and then see the ECG, does it match?
चलो, let them see the ECG.
Yes.
बोलो.
Sir, rate of 75 beats per minute. It is sinus because
Don't
each
say me because.
Yes.
Go ahead.
axis of 50 degrees and P wave is notched and
Highest thing what?
left atrial enlargement, sir.
Are you convinced about P waves? Notched? किधर दिखता है
In
P wave?
V1, there is some amount of negative deflection, whether it's more than 1 millimeter lateral.
Notching would be seen in the lead too,
Who is
sir.
going to discuss the operative?
Mm.
You. So you take a paper and go on writing the problems you are expecting in this case. What's her name? Lakshmi. Okay.
Next.
Suppose I am doubtful about LA, enlargement.
Yes, sir.
You are happy or unhappy? Answer is not written on the ECG. 5% time of occipital activity over. Not temporal.
Are you happy with the large LA or not happy with the large LA as a surgeon?
With a large LA, sir, a surgeon would be happier because
So this is small LA. So whole problem will be visualizing the
Visualizing
mitral wall.
yes,
So problem number 1 is going to be sternotomy, particularly where the lower half,
lower half.
where she had discharge. And here you are seeing radiolucency. Number 2, size of the LA.
LA.
Next.
Do
Sir,
you do
the
any other
PR
test
interval is
today?
normal.
Sir,
And
sir, Dr. Bashi is asking something.
To find out the space between the heart and the sternum, today, do you do any other test which is much more accurate than a plain X-ray, if facilities are available? That is very important. So
Tell.
that
CT, sir.
CT scan.
CT.
Correct.
stenogram, CT, always, if facilities are available, that will give much more information than the plain X-ray.
Okay.
Thank you.
Okay. Then,
Sir, the PR interval is normal and signs of LVH.
good thing or bad thing? PR interval normal.
PR interval is normal. It's a good
Following
thing.
an aortic wall.
Yes, sir.
It's good thing.
Yes,
Okay.
sir. The conduction is preserved. That's why. Yes, sir.
Next.
And signs of LVH can be seen in V1 and V6.
You are more worried about LV with strain.
LV with strain.
Strain pattern.
Yes.
So unlikely. So
No, there hardly
myocardial,
any LV.
myocardial, third problem, myocardial protection.
Protection.
Okay.
Yes, sir.
Chalo. Next. Echo. echo please, LV by voltage, LV hypertrophy by voltage, present or not present. You are supposed to tell.
Yes.
Chalo. Then go on reading.
Sir, from the starting or the
Whatever you want to highlight, you can highlight. By the
Sir,
way, for your knowledge, we all can read English.
yes.
IVC partially
IVC
collapsing
partially.
means what?
That means there is no congestive heart failure, sir.
Excellent. Now your problem starts in the 7th or 8th statement. Thickened leaflet,
Okay, yes, sir.
submitral fusion, mitral valve area 1.8.
Both
So
commissioners.
our fear of small LA is true.
True.
And now you will wonder what to do that mitral valve, whether to open LA or not, will be the question asked to you.
Do you want to open the mitral valve?
Do you want to open the LA first
LA.
of all or not? And after that, what will you like to do to that mitral valve? Will be a question asked. Nobody knows the answer. Understand? You
Here-
should be able to give plus minus answer.
In this patient, what other things? See, they're saying thickened leaflet, submitral fusion, valve area 1.8 on planimetry. What is the immediate other number that you need to look at as in relation to the mitral valve?
Sir, effective valve orifice area.
What do they do ER in your hospital for a OMV?
No, sir.
I'm telling you, valve area they have given as 1.8 by planimetry. Anything else you would like to see?
Sir, the gradients across the.
What is the gradient?
Gradient
mentioned.
Mentioned.
It is
Sir,
mentioned, sir.
15 by
Very
5.
Oh, last.
So if it is 15 by 5, what do you think is what is the confounding factor about valve area in a OMV? Post OMV. You can have a commissure which is
Commissure.
split, but the subvalvar
Subvalvar.
may be high. Is the subvalvar it is 15 by 5? By the way, it's my case, so tell it's done well. I've done, tell that I've done. So I'm just joking. But what I'm trying to say is that even after how many years?
12 years, sir.
12 years, the gradient is still 5.
5, sir.
It's good.
Good, no?
Yes.
Good
Okay.
or bad? Better tell me good, no? I've done it.
Yes.
Yadava Institute.
Yeah, okay.
Yes.
Then continue.
Sir, post AVR plus OMV status, aortic bio.
Aortic aorta
Next.
size. वो conclusion मैं भी पढ़ सकता हूँ.
No, then what do you have to say? Aortic bioprocesses?
Increase gradient across the aortic.
How much is it?
Mean of 47.
74.
Mean of 47.
Mean of 47.
More important to surgeon, grade 1 AR.
What is the challenge now immediately in your mind?
Sir, myocardial protection will be.
Root cardioplegia.
Root-
Not going to.
Myocardial protection is a one full textbook. Root
Cardioplegia.
cardioplegia or osteal cardioplegia.
Osteal.
What is the problem of giving osteal
Osteal.
cardioplegia?
Sir, it can lead to.
This case.
This case.
This case. We are talking this case. We are talking operation. Answer is not written on the 5% time. Occipital lobe work is over.
Sir, there
Not
might
before
be
parietal.
Not might be. What is the issue in giving root cardioplegia?
Struts prevent
difficulty.
the visualization
Visualization.
of
Yes, sir.
Or
ostia,
Ostia.
both. And even if you see to reach,
to insert the cannula.
insert a cannula with the presence of strut is difficult.
Challenge. So what
So-
will you think in your mind immediately? I'm going. What plan B do you have? I cannot put the thing.
Retrograde
So you're
cardioplegia.
Thank you.
Thank you.
So you should be ready with your retrograde or cool the patient as
Patient.
much as possible. Okay?
Yes.
And then spend 10-15 minutes of time in removing the prosthesis. Third possibility, if you can hold a ventricle well, give a root cardioplegia because AR is only grade 1.
Grade 1.
Okay? Bashi sir,
Anything else you want to see there?
sir,
Yep.
root cardioplegia techniques, okay?
I
Yeah,
am
that's
concerned
fine.
about
I
some.
think one has to take a little extra cardioplegia into consideration of the AR. and
Yeah.
then give through the route till the heart arrests reasonably, and then open.
Understand
Yeah.
what sir said? So give root till the heart arrests reasonably, and then you give your ostial.
Now, I have a
But you are perfectly right in saying, I will keep my retrograde
Okay.
cardioplegia delivery
Ready.
ready.
Now, I have a in this patient, not related to aortic and the mitral. Well, the mitral gradient is supposed to be normal. There is some other number there which makes me worried.
TAPSI
No, TAPSI is what? What TAPSI is 15,
15.
but something else is there. Can you see something? PASP is what?
RVS.
50 with a normal mitral valve gradient and the PSP of 50. What are you going to think of that you should rule out?
Or you will look for organic
Or
track cuspid valve
Disease.
disease.
And number two, you'll also check for lung function in this
Lung
patient because his PA pressure is rising. You will can get into big trouble. You are thinking that the mitral valve, assuming that the mitral valve is normal, the patient has got no business to have a PA pressure of 50.
50.
So you, when you do your redo protocol CT, you will also check the lung. In the HRCT lung, you will have a look at the HRCT lung, try to find if there is any emphysema. Typically, a female patient from rural area working in front of a chula, no, chula, that
Yes, sir.
firewood, this thing can have COPD.
Yes.
Okay. Smoke induced.
Patient has undergone open heart following BMV. Otherwise, after BMV, keep in mind possibility of an ASD.
Yes.
Puncture
Okay.
site.
Cardiologists feel insulted. They say our modern cath makes hardly any puncture, but just keep in mind for your air to be sucked, you don't require 2 centimeter size ASD. 2 millimeter size ASD.
And another thing is for those who are doing transeptally, some of us open the RA and place a cardioplegia, do all that work and then sit and clamp the heart. So, but if there is a PFO, you will have air sucking in all the more with the valve area of 1.8.
And the previous OMC, the Cooley retractor invariably causes hematoma in the interatrial septum. So going through the septum is not an easy, it is possible, but not an easy method of approaching mitral valve. Just keep this in mind. Okay. So the previous patch, ASD patch or a hematoma, the Cooley retractor, the last part, the tip which goes inside always causes bruises on the interatrial septum.
If you have to do OME in this patient, will you do it first or will you do the aortic valve first?
This patient, sir, is asking,
Yes.
how would be your sequence of attacking the valves?
Sir, we'll address the mitral valve first.
Thank you. I want
Problems.
problem.
Sir, small LA and
One problem
One problem.
that we only told you.
And when I retract, what will happen?
sir, when there is retraction, then chances of AR will increase.
What air?
AR, sir.
अरे
You're
cross
going
clamp.
to cross clamp the heart.
My God.
You're going to do it under fibrillation, na?
तुम लोग वो सांप सीढ़ी का खेल में एंजॉयमेंट लेते हैं यार. क्रॉस क्लैम्प किया, कार्डियोप्लेजिया दिया है. She is trying to protect you by ringing the bell. अरे the Cooley retractor with the aortic prosthesis over there, you won't be able to retract. If you are able to retract, you won't be able to see the annulus.
So
That was a tricky question he asked.
The question was specifically asked for that reason. What is your sequence? You will not be able to reach the mitral valve. What is going to be the sequence? Exercise the aortic valve,
Then
go
for
to the mitral valve, finish it, and then go back. I'm going to ask
Come
you.
back.
I am going to do a redo OME 2 millimeter to make it back to 2 centimeter plus. How will I test my OMV?
Tendolkar maneuver,
Police
catheter,
Police catheter.
ascending aorta.
Place a catheter in the
inject.
Foley in the
Foley.
ascending aorta, and then you inject here and then see. Understood?
What is your name, dear?
Sir, Dr. Avneen Tripathi.
तो डॉक्टर बोलना
Avneen,
भूल नहीं
sorry,
जाता
sir.
यार मैं
By the
Avneen
way,
Tripathi.
सारे डॉक्टर
we are all doctors
Okay.
here. In
अच्छा,
such
Avneen
a
ji-
August audience.
Avnichi, that small LA, that Cooley retractor is not there on the table. What will you do? You like to have small coolie retractor, na?
Yes, sir.
Smallest size. वो सिस्टर बोलती है सर क्या बात करते हैं हाय किधर हमारे पास नहीं है. What will you do quickly? Out of crossline man. बोलो कान में बोल कल वो चैंपियन एब्सेंट है आज.
Approach through the RA and then through the septum.
ओपन डेले man.
What can you use instead? I'm beckoning
You
you
can
to. I am
do Langen-Beck
beckoning you. I was
retractors.
trying to tell.
In fact, develop coolie retractor because previously people used to use 2 Langen-Beck retractors. So both the hands of one assistant were occupied. So coolie developed this retractor. So one hand retraction and the other hand of the assistant is available for helping. Got it?
Yes.
Commonest question in this case will be, how will you expose the mitral valve well? Various techniques. What structure can be damaged if you go superiorly? Redo case, particularly. You're opening LA and you go superiorly. What structure you will damage? Sorry?
Circumflexa.
Circumflex coronary artery. On LA, going superiorly. तुम सांप सीढ़ी का वो सांप के मुंह में जाकर जीरो में ही जाना चाहता है. मैं तुमको उठा रहा हूं खाई से और तुम ना मैं खाई जाना हूं.
By the way, we never asked about opening sternum.
Sir, the aortic valve can be.
LA. Go superiorly.
What
That means you
structure
have
is
not
there?
done mitral valve surgery.
Upper part of the LA, what is it?
Upper border, sir has told the answer also.
Yeah.
And it is all adherent there. And your scissor goes and catch, and you do something nonsense.
Conduction system, the
Ray
right
conduction, kaisa man, you're on.
Your conduction
that?
system on LA.
It's a large blood vessel.
Right pulmonary artery. You must define right pulmonary artery and superior surface of LA. There is a sulcus. There is a groove. You have to define it. Surgeons have opened, in trying to get a bigger view, have opened it. What are the various maneuvers to see mitral valve
Better.
in a small LA? Don't tell me transseptal. Huh? You have opened LA. What are the various things you will do to see mitral valve well? Hitch the right side of the pericardium. Down. Okay? Tilt the valve. Tilt the patient. Open the sternum slightly to the right, which you otherwise also you will do. Next, you can take a T-shaped incision. T-shape. Across the septum. Going towards RA. Okay? For that, you will have to loop SVC and IVC.
So if you have looped SVC, IVC, snare it up, pull it up. Both sides. That also brings it up a little bit. Then something else which you would like to do. I'm only, after doing all this, I only see the lower margin of the mitral valve. See,
There might be adhesions.
no adhesions. You have already gone into the
You are inside the LA. What adhesions?
LV apex.
Yeah, he's not wrong.
No, but
So
LV
clearing
apex.
the left AV groove.
AV groove.
And LV apex otherwise direct slightly upwards.
Actually, what prevents you actually more than the apex? What actually prevents you from seeing the mitral valve? If you are talking of adhesions, it is the LA adhesions around the LA appendage that actually ankyloses the pulmonary, the LA appendage pulmonary vein down. And even if you retract much, it is difficult to see. The other thing that you can
Over
do.
ना? Time pass. चलो time up. वो तीसरा लड़का किसके लिए आया था? हाँ? वो हमारी शादी में कोई होती है ना? शादी में साथ जाते हैं दूल्हा दूल्हे के साथ. Anyway, good. Given a big hand. From Lucknow, they have come and they are willing to present cases. Excellent. Thank you, Dr. Bashi.
Yeah, I'll get.
Sir, every day. Are sir,
So any comments for the candidate's performance?
Sir, your comment, please.
Yeah, they have to really read a little bit more regarding all this. Plus, I don't know whether they have seen a redo procedure in their unit. That also they didn't tell us actually. Like, so redo is a very challenging thing, and you have to see some videos before you go to the examination. and see an operation being done properly.
Yeah, you must know there what is the type of saw that you use, how do you release the adhesions, what are the structures which can be damaged during opening of the sternum. What do you do if you injure innominate vein? What do you do if you injure the aorta? What do you injure if you injure the RV? Each one of those things have to be planned.
Plus, opening the sternum and dissection is the most important part in a redo.
Yes.
If you meticulously open, get excellent hemostasis with the diathermy, and it should be like as if the chest is about to close. Otherwise, you should not proceed with the operation. That's what I always tell. Release everything very nicely. There should not be a drop. As much as possible, get the hemostasis. Most important. Otherwise, in the end, everything will start bleeding, and bleeding, you won't be able to control everything, especially the operation is going to be a little long. So you have to remember all these things and practice it when you start doing and read about all those things before the exam. Otherwise,
and you should know the levels of preparation of a redo.
Yeah.
Level 1, level 2, level 3.
Thank you, sir.
Thank you.
Thank you.
Thank you.
We will now proceed to the next session, masterclass. We have Dr. V Bashi, sir, talking to us about surgical steps for AVR and Bentall procedure.
I think my video is there, no? You can play my video.
Sir, we'll go through the same incision of the aorta or a new incision. Advantage, disadvantage. Everything has got advantage. Same aortic cancer.
Good afternoon from Chennai. I'm sorry that I'm not able to be present at Bangalore. At the outset, I am thankful to Hiremath and his team for organizing this teaching program and inviting me to take part in this. The first video I'm showing is going to be the surgical steps of aortic valve replacement. I have not included the indications and other details because all those things you can read from textbook. I will go only to the surgical steps, particularly from cannulation onwards. After the, usually I infiltrate antibiotics in the skin for most of the patients before the skin incision. That is what you are seeing now. Usually cefuroxime diluted in saline is injected. And that has really helped in the incidence of skin infections in my personal experience, which I've been doing for almost 30 years. And usually we take purse string with the proline. And in aortic stenosis, the aorta may be thin. One should be careful in taking the purse string. And the ideal is to take purse string opposite the innominate artery. So if you make a deep bite on the aorta, sometimes it can produce some hematoma. And you can stop it by just pressing for a minute. Nothing to get worried about in case accidentally you pierce into the media or into the lumen. The second purse string, usually I always take a pledget, because many times in aortic valve replacements, after decannulation, the aorta is thin. You may end up in taking a pledget in the end. And if you have done a high cannulation and if the pressure is high, taking a stitch at that time may be difficult, especially when you are starting open heart surgery in your personal experience. So it is better to take a pledget, and I use 4-proline with a 17 mm needle for the purse string. You can see the dilated aorta due to postnodal direction. Another very important point in aortic cannulation, even leave alone in aortic stenosis, any aortic cannulation, always make sure the blood pressure is below 100. Sometimes, initially the blood pressure may be very high, maybe 140, 160 also, but never cannulate the aorta at that high pressure. Either you can ask the anesthetist to reduce the blood pressure by pharmacological agents, or you can cannulate the right atrium first and empty the venous line and reduce the pressure. Now this connector you can just watch. I'm putting a connector with a Y. And there is a tap on the side, you can see. The air bubble is there. You clamp on both sides. Put a syringe. Release the clamp on the aortic side. And then aspirate the air. Many times when you try to connect, the perfusions will be running the pump. Sometimes you may have a clamp there. You open the aortic cannula. Connection becomes a little bit messy and blood will be splashing all over the place. Then using this particular connector is very helpful. If it's available very freely, it is very so easily you can just put two clamps and aspirate and get out the air. So when the atrial appendage is good and big size in most of the cases, you can put a side biting clamp and you make a sufficient opening. It's very important because most of the time the venous cannula not going in properly is because you have not made a properly wide incision in the right atrium. You'll be struggling to push, and in the bargain, if it doesn't go into the IVC, you can very rarely perforate the right atrium, which could be disastrous. And usually just take forehand stitches. 4 bites will be only enough. 2 on either side or at the end and 2 on either side. Either you can use Prolene if the atrium is thin, you can use Foroprolene, or you can use any of the Dacron sutures with or without blood jets. And usually I hold the cannula with the left hand, it has to just slide in. The direction is good. Sometimes IVC valve may be prominent. In that case, you can use the right hand under the IVC to guide the cannula. So these are the few steps we always, as you know, putting the patient and connecting the patient to heart-lung machine properly, the most important part in any open heart surgery, because the life of the patient is dependent on these two. Make sure the cannulas of the aorta and the venous system is well secured and tied. And always we use the superior pulmonary vein vent, as you know. Make sure there will be a little bit of fat in the area of the superior pulmonary vein. So if you try to take a purse string through that, in the end when you tie it, you will cut through and that hole will be leaking. So make sure with the scissors, dissect off the fat and take the suture close to the left atrium, not towards the pulmonary vein, because towards the pulmonary vein, sometimes if you take a deep bite, you can narrow the pulmonary vein. So, and also at this stage, you must ask the perfusionists to fill up the heart so that air should not go into the left atrium. It's all very important steps. And you make a bend in the left ventricular vent cannula. And as soon as it crosses the mitral valve, remove the stillet. That is the trick. Many times, if you don't know the trick, the cannula may not be sliding inside. It's so important. As soon as you cross the mitral valve, you can feel it. You just remove the stillet, then it will slide through. With the stillet, if you try to push through, sometimes you can injure the ventricle or the atrium. Now, before cross-clamping, it may be nice to identify the site of arteriotomy. It is important that you should not make the arteriotomy in the aorta neither too high or not too low. When you are implanting tissue valves, you should better to make a slightly higher aortotomy than a lower aortotomy, because the strut of the valve may come in the closure of the aortotomy. So make sure that you make a mark, because once the aorta, when the cross clamp and collapse, you may make it the wrong place. And another thing also I have to tell you is that nothing to worry. If the aorta, after aorta is cross clamp, there's a lot of blood inside the aorta, heart will be still pumping. So you wait, put the vent on suction and empty the heart nicely. There is nothing wrong. When the aorta is cross clamped, 5-6 minutes of ischemia is not going to do any harm to the heart, I can assure you. Because I've seen in a hurry, you cross clamp, you have to give cardioplegia. There is no need to hurry through. So all these things, splashing blood, all those things can make your field unsterile. It can splash on your face and it will fall back into the pericardium. So when you are implanting a prosthesis inside the heart, very important is to follow meticulous aseptic techniques. I will reinforce about 10 times about the aseptic techniques. Any amount of antibiotics is not enough for a sloppy technique in your asepsis. And when you give cardioplegia also, you have to be careful. Make sure that the ostia, you are properly inside, and make sure there is, if it is a short left main, sometimes you can selectively give cardioplegia into one of the branches of the left coronary artery. I will show in the next video when I show the Bentall's operation in little more detail. And you exercise, because in most of this is not that very heavily calcified, but in very heavily calcified aortic valves, you exercise a small portion of the valve and pass a gauze piece inside, a wet gauze piece you can pass inside, so that a small amount of the calcium debris going inside, you can easily take it out along with the gauze piece. And be sure of the conduction tissue. Make sure when you especially you exercise the right coronary cusp, don't go very much deep into the muscle. Ventricular septum especially will be there, the membranous septum in between the known and the right coronary. This is, you can see the bicuspid valve with a very thickened with the calcification. And I would suggest that is the valve we can see. You should take your time to decalcify it properly and remove all the calcific debris. It's so important. Then you put the sizer so that, before taking out the gauze piece, I always put the sizer so that when you put the sizer, some calcium may get dislodged. That also can go into the LV. It may go into the gauze piece and be there. When you remove the gauze piece, everything can be taken off. All these steps are very important. There is no step in open heart surgery which is not important, in my opinion. Another is afterwards you give a wash. When you are giving a wash, then make sure your assistant put the tip of the soft sucker into the left coronary ostia, because sometimes small pieces of calcium can go into the left main and can produce embolization, which could be disastrous. When trying to come off bypass, you won't know that embolus has gone in the left coronary artery, can produce perioperative infarction. And I use small plate-jetted sutures, usually in the subannular position, or you can in the subannular position or supraannular, depending upon the valve which you are using. In tissue valves, I always use all subannular. This is an old video only. This valve is the tissue valve, which actually at present it is I think it is out of the market. So I use always interrupted sutures with the plate jets. And this holder has to be kept on the valve, especially when you tie the tissue valves, because tying the sutures sometimes can injure the cuspal integrity and can produce trauma to the cusps. So make sure that the assistant is holding the aorta properly and the sutures are tied. When you use mechanical valves, especially our Chitra valve, you can say if we are using plate jets, at least 4 or 5 sutures, you must use the plate jets in the supraannular position, because when the lesser orifice, when the disc opens, the lower part of the disc can impinge on the plate jet and sometimes can produce non-closure of the disc. So when you are using Chitra valves, and if you are using plate jets for seating the valve, at least 4 or 5 sutures, the plate jet has to be supraannular. The rest of them you can put under the annulus. So once the valve is seated, you remove the holder. And another thing also is before seating the valve, it is better to rotate the disc, rather than, suppose after implanting the valve, sometimes the Chitra valve rotators does not work and the disc may not move. So before you seat the valve itself, you must rotate the rotator so that, it will rotate in case we have to rotate the disc for checking the opening and closure. Because I had once a problem in a Bentall's case where I put the conduit and the rotator about 15 years ago, the rotator got stuck. Finally, I had to use a saw to cut and remove it. The present rotators of Chitra valve is good, but my important thing is you have to rotate it before you implant it. And this is actually a redo where I put a tissue valve. Make sure even while cutting also you should not injure. Now, next is the end is you close the aortotomy. Usually I use 5-0-Prolene with the blood jets. The corner sutures are used with the blood jets because usually when you release the cross clamp, the corner is the one sometimes it can, once the pressure is high, and if you have done a big aortotomy, the corners can bulge and can produce bleeding. Sometimes it may be inaccessible if it is the posterior part of the aorta. So it's always better to be safe than to be sorry. And you take your own time to do these procedures. One thing I want to tell the students is today, with the cardiopulmonary bypass, with the membrane oxygenator and good cardioplegia, topical cooling, excellent myocardial techniques protection techniques are available. There is no need to hurry through. Olden days, we have to do operation very fast. And then, because of the bubble oxygenator, improper myocardial protection, no AC available in the theater, all those things were very important. The speed was very important. I don't think today, speed that, especially when you do a valve replacement, you make sure, first of all, you follow all the steps, use interrupted sutures, make sure all the stitches are tied properly. And then, if necessary, if you have a doubt, probe and see if there is any leak. Because when you start open heart surgery, it's very important that the first few cases, the patient has to go home. Time is not a matter, but nobody is worried about whether, doctor, you have done an operation in half an hour and the other surgeon took 45 minutes or 1 hour to do an operation. Doesn't matter at all today. I want to re-emphasize that point to the youngsters, that completeness and meticulous techniques in surgery cannot replace anything, because your results, you are always judged. You are judged by your results, not by your efforts. That is what is very, very, very important. Your merits are judged by your results and not by your efforts. You may be working 24 hours a day or 26 hours a day. Nobody is bothered about that. How many patients have died in your hands? Especially, it's very important. Your results are you work for that. That is my sincere advice to all of you. Follow the techniques. The results will be fantastic. Thank you very much. And I hope you have followed a few points. Make sure all those things are put into practice when you start your surgery. And wish you all the best. If you have any questions, I will be more than happy to answer. Thank you once again, Hiremath, for inviting me for this fantastic teaching program.
Thank you, sir. Any questions from the audience? No. Sir, is there online?
Yeah, I am here, Hiremath.
Yeah, sir, is very much here.
Very much here. Yes, Hiremath. Sorry, I couldn't
Any
come.
questions from the audience? Sir, what will be the take-home message for you, for the students, sir, from your end, for these two procedures?
No, one procedure only. Bentall is coming only. No?
Okay, no. Oh, Bentall is coming now.
Yeah, Bentall is coming. Aortic valve, as I have summarized everything, like, the completeness and of the technique. Because today, a patient comes with a paravalvular leak, the cardiologists are going with the devices. Device to close the paravalvular. That is a big business in the cardiology. So don't give a chance for the cardiologist to put a device on your paravalvular leak. So when they do echo, if everything is okay, no cardiologist will inform you. A patient has got a paravalvular, 100 fellows will come and go, sir, I did echo for that patient. There is a paravalvular leak. Of course, you can't prevent it. When there is an infection and a bad annulus with a friable tissue, sometimes it happens. But if you follow the technique, very important is to every aspect of implantation, calcium also. Don't keep too much calcium there. Remove all those things, because you will be getting more and more of calcific aortic valves. In our days, earlier days, majority was rheumatic valve. Dr. Tendolkar will know it very well. All dilated aorta annulus, easy to put a Star Edward valve and come out. Today it is not like that. Ladies with 75 years, 60 years and all coming. Of course, TAVI is there, but still, once you master this technique in aortic valve, primary valve, you will be getting more of TAVI to be explanted in the future. So better be prepared to take TAVIs, which is even more technically difficult. That's
Okay.
all I have to say.
Okay. Thank you, sir. Manpreet, we have the Bentall. Do we have another video, sir? Another video? Just
Yeah,
play
one
it.
more.
Yeah.
Bentall.
We'll just finish it. The robotic case talk has been cancelled.
Good afternoon from Chennai. Once again, I apologize for my inconvenience to come to Bangalore at this time. And thank you, Hiremath and your team for inviting me to take part in this year's core program. Bentall's operation, you should know a little bit of the history, as I'm sure all of you will know, but I'll just for completion, I'll put Hugh Bentall and Anthony DiPorno did the first Bentall operation in a 33-year-old man with a large aneurysm. And a number 13 star duet valve was used for that. And this was published in 1968 with 2 authors and 2 pages article in Thorax. And this has changed forever the face of aortic surgery in the world. Now, indication for surgery, you all know. I'm just briefly putting all these things just for completion of the talk. You can read more. I will mainly concentrate on the steps of the operation. Now, these are the few conditions where Bentall is indicated. I'm just showing a few of the CT aortograms where we have performed Bentalls for patients who come with the dissections, aortic ectasia. You can see retrograde dissection, aneurysm after previous valve replacement, type B dissection with ruptured sinus. So many varieties. You can see right-hand side, the different, the operative appearance is a dissection, chronic dissection, root dilatation. And important thing is cannulation. As I have mentioned, in the previous video also I have shown about the importance of cannulating the aorta. And always as high as possible cannulation is better. Usually you have to dissect high because some of the cases of in indications of Bentall's operation, there may be slight, it may not be an isolated disease of the root itself. Ascending aorta or proximal arch may be dilated. So you have to remove as much as possible of the aorta distally. So cannulate as high as possible. The ideal place to cannulate is the opposite the innominate artery. So other areas of cannulation are you can interposition graft with innominate artery. Usually a 7 or 8 millimeter graft can be used and use a 6-proline suture into the innominate artery. This is important in cases where we have to do the proximal hemi-arch or total arch associated with the Bentall's operation. So when you plan for an arch replacement or a proximal arch or total arch, it is better to cannulate the innominate artery. Other area we can cannulate is the femoral artery. This usually you can do in emergencies and also sometimes in dissections where patient is having a very unstable patients. It's an easy way of cannulation. Other area of cannulation sometimes maybe if there is calcification in the arch area, you can cannulate the carotid artery. All these are possibilities. Now after that, you have to, once you go on cardiopulmonary bypass with the right atrial cannulation, you have to give cardioplegia. You know, St. Thomas's cardioplegia is the commonly used cardioplegia. Del Nido cardioplegia, which lasts for 30 minutes, and custodial up to 2.5 to 3 hours you can give. One of the important things I want to show when you give cardioplegia, you see I'm holding the aortic edge with the right hand of the forceps, and assistant will be invaginating the right coronary. And with the forceps, you direct the tip of the cannula towards the surgeon's shoulder. It is very important point, because if you try to put the cannula straight into the right ostia, especially in patients with annular aortic ectasia and other, one can injure the right coronary artery. I have seen people producing the problem because with force, if you use, it can. So it is important that towards the surgeon's right shoulder, the direction of the cardioplegic cannula. And left, when you can see this is separate ostia on the left, this is okay, you can see. But when there is early bifurcation of the left main, which can be seen in the angiogram. Most of the time, sometimes you have to give cardioplegia separately to LAD and the circumflex. The next is preparation of the conduit. We use a mechanical conduit. If you use a Chitra valve, you can use either 3 sizes or sometimes even 1 size also is enough. And bioprosthetic valve, you can use about 5 sizes. That is what normally we use. So usually these conduits can be made easily. By the time the surgeon takes the annular sutures, the assistants can make a conduit, makes maximum 4 to 5 minutes only it will take. Then another way of making the conduit also is like a French cuff technique, which can be used easily. So that can be, when I come to the annular sutures, I will show you how important it is to use a French cuff technique in getting hemostasis. Now coming to the operation as such, I'm just showing a video about the whole procedure. So after going on bypass, you, as I said in the previous talk, you wait for the heart to be empty. You open the aorta and give cardioplegia. Assess the aortic root. In this case, the aortic valve we have planned to replace. And then you dissect the coronary. First, you dissect the left coronary artery. When you dissect, leave a little bit extra tissue so that, don't cut very close to the ostium of the left main. It is always better to be safe. In the end, if there is excess tissue, you can cut it off. But when you dissect it, you take a sufficient amount of tissue. This is a very straightforward case where the tissues are very good. It's a, root dilatation. There is no, not like annular aortic ectasis. In annular aortic ectasis, the tissues will be very thin. You have to be very, it will be friable also. So now that is the dissection of the right coronary ostia. Then you mobilize the aortic, you are excising the excess aortic tissue, leaving a rim of the aortic valve. Some surgeons don't excise the aortic valve, but I always excise the aortic valve. You have to, I'll remove the whole, especially in the commissural areas, you remove all the tissues, because sometimes when you see the conduit, that area, it can leak. And I always use small pledgets for the annular sutures. 2 sutures I use with fluoroproline at the commissural area, which later on is used for the additional layer in the annulus. So all these small pledgets only, which is PTFE pledgets. They make it, there's a company which makes small pledgets. I don't like big pledgets. Sometimes when you are using subannular pledgets, pledgets itself can produce sometimes outflow tract obstruction. So this is a biological conduit made by hand. Then the sutures are taken equal distance. That is very important, so that there is no leak when you see the conduit. Then the conduit is tied, each sutures has to be tied properly, and make sure there is no loop. You retract the cusp and see that there is nothing, no loops of thread inside. Sometimes some loops can get stuck, and this is the additional hemostatic layer I was talking about. This layer is very important, because when you use a French cuff technique, you can use the stitch onto the French cuff. This one is not we have not used the French cuff for making the conduit. So this is a very important hemostatic layer. That is a fluoroproline suture I use. 2 sutures from either side is taken, and it is it is sutured onto the conduit, base of the conduit. It has to be properly taken. There is spending 5 minutes extra here is always worth it. Then you pull the graft with the right angle. You make a hole. The assistant lifts the left coronary. and then right at the area you make a hole. And I always use a small felt. I mean, so a small strip of pericardium, patient's own pericardium preserved in glutaraldehyde, which is used outside the coronary button. And I use 5O multipass proline sutures for suturing. When you suture the coronaries, especially in aortic ectasia and other connective tissue disorders, make sure you don't leave much of the aortic tissue when you take the sutures. At the same time, don't go very close to the opening, because if you go very close to the left main opening, the tissue will be thin and it can get cut through. So once that is done, next step is to do the right coronary anastomosis. Now the left is almost getting complete. Always make sure the bites has to be taken as close as possible, and the assistant has to hold it tight. Sometimes you can use a nerve hook to tighten it before you tie it. At the same time, right coronary, if you lift it up, it will reach. There are some surgeons who release the cross clamp to open the graft so that right coronary is positioned properly. But in my experience, I don't think it is necessary. The assistant pull the coronary up, and with the right angle, you just you make a hole in the graft. Sometimes there will be a lot of returns for unknown reasons when there, from the right coronary that obscures your vision. So you can put a bulldog clip on the right coronary, nothing wrong in that. And another thing also, you find accessory minor arteries may be there in the right coronary sometimes. Don't try to cut that or exclude that. Whenever possible, just include an accessory artery along with the right coronary, because sometimes it can create trouble when you are coming off bypass, some RV dysfunction. So try not to injure any coronary arteries. The same way with the pericardial pelt, right coronary also is anastomosed. Now after that, we anastomose the top end of the graft onto the aorta. You can use Teflon felt. Sometimes I use Teflon felt, sometimes I don't use. The aortic tissue is thin, it is nothing wrong. But in annular aortic ectasia and other connective tissue disorders, I use an additional strip of pericardium inside the aorta, because the needle hole can sometimes produce a small tear and produce leak of blood inside, and the adventitia will show a hematoma as a release of Prasanna. So addition of a small pericardial blood jet is not a bad idea, and it is not very bulky also. That you do inside the aorta. In this case, we are not using it. We are just using only Teflon outside. So after de-airing, you release the cross clamp. And then give protamine. Now, just show a few points about coronary implantation, which I was just telling. That is, you see the coronary ostia. This is not the way you should do, because then you have a lot of aortic tissue you are keeping here. So make sure you suture line close to the coronary ostia. That is important, because when you take it too much towards the periphery of the button, this area can balloon up. In especially Marfan syndrome patients, we have seen some cases. In fact, I don't have in the slide, I don't have it now, because at least 2 or 3 cases I have seen the buttons has become aneurysmal, where people have done the coronary button very big. Now, another thing is, especially when you start doing Bentall's operation and all that, always better to be safe. So after doing the coronary buttons, better to use a Fortis catheter and give some cardioplegia, and ask your assistant to wash and make sure there is no bleeding, because especially some inferior part of the coronary bleeding can be disastrous after coming off bypass. So you wash with this saline, you can see it is watertight, and then hemostatic on the right, and you cut off a little bit of that Fortis catheter, because sometimes in a tissue valve, this polycatheter can go inside the valve and can produce incompetence. Just cut it off, inflate it, and check that. That is also a good technique. So all these are important. Reinforcing around the annulus, that stitch I showed you, a hemostatic is a blood saver, I say. This is a life-saving suture because, so many times bleeding can occur in this area. Native pericardial strip is very good. And also a time saver because bleeding from the coronary anastomosis, even if you have done hundreds of Bentall's operation also, I always make sure this coronary anastomosis is done properly. It's very important. Otherwise, all the whole day you will be spending in the theater without much success. Now, special scenarios are, when there is calcification in the left coronary artery or in a reoperations, when the left coronary is very short, you can see a lot of calcific plaques in this left main. So use what is called a Cabrol's procedure, whereby this is a 10 millimeter Dacron graft, and then you anastomose it to the left main. So the needle is not going, almost it is bending. You can see the force with which I am trying to pierce the left main. It is so thick it is. So in this case, it is always better to use a Cabrol's procedure. And when you do Cabrol's procedure, when you decide to do it, don't implant the conduit before. Conduit is always seated after doing the distal anastomosis. Then you anastomose the proximal end onto the ascending aortic graft. So release the cross clamp. This length has to be measured correctly, otherwise it can kink. You can see the postoperative picture, you can see the graft is lying very nicely. So when you have find the coronary, left coronary is a little bit, you are not able to mobilize it properly in reoperations or when there is any calcification, there is nothing wrong in doing a Cabrol's procedure. And this is in aortic dissection. Of course, in type A dissection, sometimes dissections can get into the coronary ostia. Sometimes the right coronary may be badly dissected. And if it is badly dissected, if you cannot repair it, don't waste time in doing that. You can just close it off and put a vein graft. Whereas when it is repairable, you can repair it and then do that. So that is the left coronary, right coronary. I think this video is shaking. Yeah. So there is a repair of the left main coronary ostia. So in conclusion, aortic root replacement can be done with excellent early and late results. And currently in experienced hands, the mortality of that is same as that of aortic valve replacement. Button technique reduces the bleeding and late pseudoaneurysms, as I mentioned. And patients who have connective tissue disorders may need surveillance for the distal aorta. And another thing also I can tell you is that every Bentall's operation has to be treated with enough seriousness, because even after doing more than about 600 Bentall's operation, I don't take a single case as a very light case. One case, I think it is going to be easy. That case will give me trouble. So make sure if you follow all the steps meticulously, starting from cannulation till coming off bypass, you can produce good results. Because with availability of all the good sutures, with magnification, with myocardial protection, and good oxygenators, cardiopulmonary bypass time is nothing to worry, I would say. Don't hurry through to do a Bentall's operation. When you are going to do a Bentall's, and if you have not done many cases, previous dates, and you go to the theater, mentally prepared, whatever it is, the time taken, I will do this case meticulously. If you do like that, you can produce excellent results. Thank you very much. Once again, I thank Hiremath and his team for allowing me to take part.
Thank you.
This,
Thank you, sir.
teaching
Thank you so
program.
much.
Thank you, sir. We now next have a talk on palliative surgeries, bands and shunts by Dr. K. S. Iyer. Can we have the video, please?
I will leave Hiremath first.
Yeah, thank you, sir. Thank you for joining.
Thank you.
We are running late, sir. So,
Yeah. Go ahead. Thanks.
so questions I cancelled this time. Okay.
No problem. They can write it.
Recorded. Iyer, sir, is there. Yeah.
Okay.
Iyer is there on board. Iyer is there. Yeah.
Sairam, a very good evening to you all. At the outset, I'd like to thank Dr. Hiremath and his team for inviting me to participate in the IACTS Core 2025. I have been asked to talk about shunts and bands. We'll do shunts first. So what exactly do we mean by surgical shunts? A shunt is any conduit or connection that bypasses some blood from one circulation to another through an extra anatomic pathway. So we can have different types of shunt. The systemic arterial to pulmonary artery shunt, for example, the Blaylock-Taussig-Thomas shunt, the Pot shunt from descending aorta to LPA, the Waterston-Cooley shunt, the ascending aorta to RPA. Now, of these three, the Pot shunt and Waterston-Cooley shunt are largely historical. They are generally not performed in current days, except for the Pot shunt, which has seen a revival in patients with Eisenmenger syndrome. The commonest amongst these is the Blaylock-Taussig-Thomas shunt, which you'll all be familiar with, which is a shunt from the systemic artery, usually the subclavian artery, to the ipsilateral pulmonary artery. Then we can have venous shunts, the systemic venous to pulmonary artery shunt. For example, the Glenn shunt, which is a shunt between the superior vena cava and the ipsilateral pulmonary artery. And lastly, you would have also heard of the Sano shunt, which is used in hypoplastic left heart syndrome, which unfortunately is a misnomer, but is exactly not a shunt. It's essentially a right ventricle or a systemic ventricle to a pulmonary artery conduit. Going back to a little bit of history, the first Blaylock-Taussig, as it was originally known, was done in November 29, 1944 by the surgeon Alfred Blaylock on the recommendation of the cardiologist, whose name was Helen Taussig, and therefore the shunt came to be known as the Helen Blaylock-Taussig shunt. And this was done at the Johns Hopkins Medical Center in Baltimore. But of importance to realize that the unsung hero who was at that time the person who actually helped Dr. Blaylock do the shunt was a black technician who worked in the lab and who actually devised the clamp which he used during the time performance of the shunt. And therefore, much later, he was given due recognition, and that's why it's now called the Blaylock-Taussig-Thomas shunt. So it has undergone changes over course of time. On the left, you see what is known as the classical Blaylock-Taussig shunt, which was what was originally performed, where the ipsilateral subclavian artery was divided distally, turned down, and anastomosed to the ipsilateral pulmonary artery. This unfortunately resulted in loss of normal blood supply to that particular limb, with a potential risk of a short limb or limb ischemia. And therefore, Mark Delaval from Great Ormond Street modified this shunt, interposing a PTFE graft between the subclavian and the pulmonary artery, and this is called the modified Blaylock-Taussig-Thomas shunt. The advantage of this is that the distal perfusion to the limb is not affected, and therefore one can choose also different sizes of the shunt rather than depending entirely on the size of the subclavian artery. So what exactly does a BTT shunt achieve? Essentially, it diverts some blood from the systemic to pulmonary circulation. The increased pulmonary blood flow thereby increases the systemic oxygen saturation, and the improved systemic oxygen saturation defers hypoxia-related morbidity and mortality, and also the increased pulmonary blood flow promotes growth of the pulmonary arteries. So what are the determinants of shunt flow? It's essentially the laws of physics apply here. So flow through any tubular structure is dependent upon the diameter of that, the length of that tubular structure, the pressure head at which the blood enters that tube and the distal resistance. So here it's the length of the shunt, diameter of the shunt, systemic pressure head, the pulmonary resistance, and the proximity to the aorta, which means that the closer you are to the aorta, the larger or the higher will be the pressure head at which the blood enters the shunt. So what then are the advantages of a Blalock-Thomas Taussig-Thomas shunt? It is that in comparison to a corrective procedure, it's a short procedure and therefore useful for emergency relief of critical cyanosis and has a low procedural failure. It can be done in places where cardiopulmonary bypass is not available. It avoids the complications of cardiopulmonary bypass, especially systemic inflammatory response syndrome, and the need for heparinization, buys time for a definitive repair, and then, at least in the short term, it is a lower cost procedure than a corrective procedure. But it also has certain downsides. It's unphysiological and palliative. There are risks of shunt overflow, which means if the shunt size is too large for that patient, it can result in systemic hypoperfusion, resulting in pulmonary edema, can lead to coronary steal if the diastolic pressure is very low, and this is of crucial importance in a procedure like the Norwood procedure, where below a certain diastolic pressure, these patients undergo sudden cardiac arrest. Long-standing problems can be chronic heart failure, and which can result in persistent increase in pulmonary blood flow, can result in pulmonary vascular occlusive disease. Shunts can also block acutely. Acute thrombosis is a problem, and long-standing can cause pulmonary artery distortion. So what are the current indications for a shunt? In biventricular hearts with pulmonary stenosis, like tetralogy, double outlet right ventricle, or TGA, it's essentially TGA VSDP physiology. It's essentially to defer correction to a safer age if one is not comfortable doing these procedures at a younger age. When there's pulmonary atresia, you use a shunt to defer a conduit placement to an older age, because the corrective procedure in pulmonary atresia involves placement of a conduit, and if you can defer it to an older age, one can place a larger size conduit. Single ventricle pulmonary stenosis, that's the only tolerated palliation in early infancy. And any pulmonary stenosis with hypoplastic pulmonary arteries, it's used to promote growth of the pulmonary artery. Other indications, which are relatively rare in our part of the world, is part of the Norwood operation for hypoplastic left heart syndrome, as I mentioned, part of staging in pulmonary atresia, VSD and MAPCAS. It's also part of the first stage in a two-stage arterial switch. When you have patients with transposition, intact septum presenting late with a regressed LV, and you want to retrain that LV before doing an arterial switch, then you have to do a BT shunt along with a pulmonary artery banding. You may have to do associated procedures along with the BT shunt depending upon the underlying pathology. It could be an atrial septectomy or a balloon atrial septostomy in a patient where the ASD is the only outflow to the right atrium, like in tricuspid atresia or pulmonary atresia, intact ventricular septum. You may have to do a pulmonary valvotomy in patients with PA-IVS, whom you are hoping for a future biventricular repair. One can also simultaneously do a branch pulmonary arterioplasty if there is origin stenosis of one or both pulmonary arteries. Unifocalization of MAPCAS may be required in pulmonary atresia, VSD MAPCAS. Sometimes you may ligate MAPCAS, which are overflowing to a particular region of the lung. One may also do a PDA ligation or a banding of the contralateral side. And in a staged arterial switch, as I mentioned, one does a PA banding along with a BT shunt. What are the various surgical approaches? One can do a right thoracotomy, which would entail a right subclavian to right pulmonary artery shunt, a left thoracotomy, where you can do a left subclavian to LPA shunt. You can also do a left subclavian to main pulmonary artery shunt through this approach. You do a mid-stenotomy. You can do an innominate to right subclavian or a right subclavian to right pulmonary artery shunt, a left subclavian to the MPA or LPA, an ascending aorta to the MPA shunt, which is known as a central shunt, and an ascending aorta to the RPA. So these are the various locations where you can place the shunt and the various approaches. It's sometimes more prudent to use a sternotomy approach over a thoracotomy approach. And when is it more prudent? If the patient is hemodynamically unstable, saturations are difficult to maintain, then it's better to do it through the mid-sternotomy, keeping a pump standby, so that in case the patient crashes acutely, you can go on cardiopulmonary bypass. If there is need for additional intracardiac procedures, which I mentioned already, then obviously one needs to go through a sternotomy. If there is need for intervention on a contralateral PA, for example, if you've got left pulmonary artery origin stenosis, you can put a shunt on the right side and then do a PA plasty on the left side. Or if the patient has a chest wall deformity, where it may be difficult to go through a thoracotomy approach. So what are the differences between a sternotomy shunt and a thoracotomy shunt? Whenever you do a sternotomy shunt, then the proximal anastomosis usually is closer to the aorta. It may often fall on the innominate artery, whereas when you do a thoracotomy, you usually end up putting it distally on the subclavian artery. And this is essentially what the shunt flow will get dictated by, because if you put it proximally on the innominate artery, you're likely to have a much higher shunt flow. So because the shunt through a sternotomy is more medial and shorter, you can expect patient to have a higher flow through the shunt and have pulmonary hyperperfusion. And so the way to get over it is to use one size smaller shunt. You use the thoracotomy because the shunt has to travel a longer distance from a subclavian to the pulmonary artery. Then the shunt is a bit longer, and as I mentioned, if the shunt is longer, the flow will be lesser. So once you use the thoracotomy, then you can afford to use a slightly higher shunt size. Also because then the subclavian artery is smaller. So as long as the subclavian is smaller than the size of the shunt size per se does not matter, because it is the size of the subclavian which will regulate the flow. I'm often asked what size of shunt should you use for what weight. So general formula that I use is if you use less than 3 kg patient, you use a 3.5 millimeter shunt. I don't generally use a 3 millimeter shunt because it has a very high rate of thrombosis. Between 3 and 5 kg is a 4 millimeter shunt, and beyond 5 kilograms, use a 5 millimeter shunt. What are the factors that determine the choice of shunt size? There's pre-existing pulmonary blood flow. Depending upon what you assess as the pre-existing blood flow, if the patient already has reasonable blood flow, then one would use a smaller size shunt. If the pulmonary blood flow is very low and the saturations are very low, then one can use a bigger shunt. If there is also additional pulmonary blood flow, like a PD or collateral, then you can choose a smaller shunt. Indication for shunt, depending upon whether it's going to be a single ventricle or a biventricular repair. If it's a single ventricle, usually by the age of 5 to 6 months, you would convert it to a Glenn shunt. So you can use a smaller shunt. Also, you don't want to volume load a single ventricle. Whereas the biventricular repair, you would like to have the shunt last for a longer time. Usually you would do the biventricular repair at the age of 2 years or so. So you would use a larger shunt size. Sternotomy versus thoracotomy approach, as I already mentioned, that depending upon which approach you are using, you would use the appropriate size shunt. This is a paper which you would all need to read for historical purposes, because this is the place where the shunt was first done. They published their experience with 2,000 Blaylock toxic shunts over a period of 6 decades, just to show that the indication for shunt has changed from biventricular to now, in vast majority, only single ventricular changes, and accordingly, over course of time, the mortality has also changed. You can also see that these are patients who did not undergo a subsequent corrective procedure. You can see over course of time, there's a definite attrition if they only remain with a Blaylock toxic shunt. And these are the various causes of death following BT shunt. You can see that brain abscess, stroke, hemorrhage, and these are all problems of chronic polycythemia, because these patients did not undergo a subsequent corrective surgery. Is it possible to live long with a shunt alone? Well, anecdotal reports are there. There's this report from Japan where a lady lived to 72 years of age with just a Blaylock toxic done, which was done when she was 10 years old. Now, you should know that the shunt carries a certain level of mortality even in the best centers. So this is data from the STS-CHS database a slightly older report, but just to show that amongst the neonates, mortality is about 7.2%. And the risk factors for death are need for preoperative ventilation. Pulmonary atresia intact ventricular septum is a particular group which has a particularly high risk for mortality following shunt. Single ventricle physiology over a biventricular repair has a higher shunt, weight less than 3 kilograms. Important to note that 1/3 of the deaths occur within the first 24 hours and 75% within the first 30 days of the shunt. In the current era also, mortality has not changed significantly. So this is a more recent single center experience from Toronto Children's, again showing that there's a 12% mortality, and the majority of the mortality occurred in neonates and in the single ventricle physiology. Likewise, if you look at the various morphological entities for which the shunt has been done, again, as I mentioned, single ventricle has a higher mortality, especially the group with pulmonary atresia intact ventricular septum that has the highest mortality. Shunt failure is an important cause of early mortality, which can be either acute shunt thrombosis or shunt overflow. And you can see from this data that if there is shunt failure, then the mortality is almost 3 times higher. So if there's shunt failure, the mortality was 32% compared to no shunt failure, where the mortality was 10%. How can you reduce shunt mortality? Basically, to reduce shunt failure or to block, surgical consideration is important, also anticoagulation management and a tailored postoperative management. It's important to have meticulous attention to detail, depending on the site of the shunt, the size of the shunt, length and lie of the shunt, and the suturing technique. So it's important to see that ideally a shunt should lie like this. Because the subclavian artery is at an angle, the upper end should be beveled, and the pulmonary artery is more horizontal. The pulmonary artery should be exactly at 90 degrees. So you can see a proper shunt lie is important. That's also important after the shunt is to milk the shunt like this to make sure that there are no early clot formation, which can be squeezed through and the shunt remains patent all through. Also, in the postoperative periods, it's important because the shunt increases the pulmonary blood flow. So ventilatory as well as pharmacological management has to be done to maintain that balance of QP-QS. You know that a high FiO2 decreases the PVRI and will increase pulmonary blood flow, whereas respiratory acidosis will decrease the pulmonary blood flow. So you have to manipulate the ventilation as well as the inode dilator therapy in order to titrate that shunt flow accordingly. So the principles of management essentially is moving on from invasive to early non-invasive ventilation. You maintain modest hypercarbia. And if there is lung injury or reason for that, then it's better to ventilate longer and not extubate in a hurry. Feeding is also important. So to conclude, the BTT shunt has an important role in congenital heart surgery. It remains the gold standard against which other treatment modalities are compared. And the key to optimal outcomes depend on the surgical strategies and postoperative management of QP-QS alterations. And this can be optimally achieved by appropriate ventilatory and hemodynamic strategies. So I'll now move on to pulmonary artery banding. Again, historically, the first description of the pulmonary artery band was by Muller and Daman in 1952. And as you can see by the diagrams, the first time they did it, they actually excised a portion of the main pulmonary artery to reduce its size and then put a band around it. So this is different from what we do nowadays. The current indications for pulmonary artery band, first, of course, is again to control increased pulmonary blood flow. And this is in situations where the pathology is not amenable to corrective surgery. For example, a Swiss cheese ventricular septal defect. In univentricular hearts with increased pulmonary blood flow, may do a main pulmonary artery or a bilateral branch pulmonary artery banding. In borderline biventricular hearts, where you would want to defer the decision for a biventricular heart to a later date. And if there is a medical contraindication for cardiopulmonary bypass in a patient who is having unrestricted pulmonary blood flow, then you could tide over by doing a pulmonary artery band. You can also put a band to increase the ventricular afterload with the aim to prepare the ventricle. This would be like LV preparation in TGA or CCTGA with a regressed left ventricle. And situations where you want to regulate the pulmonary blood flow in conjunction with the bidirectional Glen. So in a single ventricular situation, we have done a Glen and the Glen is not providing adequate saturations. One can band the pulmonary artery to leave some antegrade flow. And then, of course, there's a debatable treatment option which has been described in patients with early Eisenmenger syndrome and with dilated cardiomyopathy, where there are some reports that PA banding might help these patients. The surgical approach, again, it can be through a left anterolateral thoracotomy in situations where there's normal great vessel relationship and no additional procedures required except for PDA ligation, which can also be done through the same incision. A left posterolateral thoracotomy, when you're doing a PA band along with something like, for example, a coarctation repair. Right thoracotomy with a BT shunt for situation where you're doing LV preparation. But usually a mid-stenotomy is used. It can be a partial upper mid-stenotomy or a complete stenotomy. And this is useful in patients who have malposed great vessels or there's need for intracardiac procedure, like for example, an atrial septectomy, or if the patient is hemodynamically unstable with a potential need for cardiopulmonary bypass. What are the types of band? You can have fixed surgical band or an adjustable surgical band. An adjustable, you can adjust the band either by leaving the sternum open and thereby reducing or increasing the size of the band, or there can be adjustable bands with a closed sternum, and there are many techniques described in literature for that. There was historically an implantable externally adjustable band called the Flow Watch, which was there for a few times, but then got withdrawn from the market. And then cardiologists also sometimes use what's known as a percutaneous flow restrictor device. The band material can be either a silicone-coated umbilical tape, can be a strip of PTFE, can be a polyester tape, or an absorbable suture like Vicryl if you want a temporary banding. Or what I prefer to use is this Merceline tape. This is basically a suture which is available for sternal closure. It's a band which is of polyester material, but it's relatively inert and does not cause a tissue reaction. How tight should the band be? Various formulas are available, but in general, if you want to do it for controlling pulmonary blood flow, then one generally uses the Trussler's formula, which is 20 millimeters plus weight in kilogram for a ventricular septal defect, or 20 plo plus weight in kilogram for univentricular hearts. But more importantly, you need to do an intra-op assessment by needle manometry or by echocardiography. And the distal mean pressure should be for a ventricular septal defect to drop it to less than half the systemic or 20 to 30 millimeters absolute pressure. And for a univentricular heart, you need to drop it to less than 20 millimeter mercury because you need to really protect these lungs. The saturation on 50% FiO2 should be more than 95% when the patient has a left-right shunt, and at least more than 85% for a single ventricle situation, or not more than a 10% drop from the preoperative saturation. Patient should not have any bradycardia and should not have any systemic hypotension. For LV preparation, an intra-op assessment is important again by LV manometry or echocardiography, and a band gradient of 30 to 40 millimeters of mercury is generally acceptable, and the LV systolic pressure should be risen to 60 to 70% of the systemic pressure. Again, there should be no bradycardia or systemic hypotension, and the central venous pressure should not increase by more than 2 millimeters. At the same time, on echo, there should be no evidence of acute left ventricular dysfunction or strain. What are the complications of pulmonary artery band? It can be either too tight or too loose. The band can migrate, band can erode, and band can get infected. So I'll just show you a surgical video of how a pulmonary artery band is done through upper hemistenotomy. So a 3-month-old kid with a large VSD and also a Swiss cheese apical septum. So that's just the echo to show with the multiple VSDs with the color flow. And you can see here that the sternum has been opened partially, sternotomy. A single blade retractor has been placed, and you measure. This is the Merceline tape which we use, and you measure the approximate size of the band, put the marker stitches. I'm sorry. So after the markers, stitches are put. Then one passes the right angle over the pulmonary artery. You get that tape across.
What is the subtraction technique?
We put a first ring suture distally
Mike,
and
take
put
the
a
mic,
needle
please.
in for manometry.
Sir, initially the
Slowly, that's the basal starting pressure. You can see that. And we gradually tighten the band. Same time, you can see that now the pressure has dropped. It's important, the saturation remains 100 and there is no bradycardia. So at that time, we've dropped the pulmonary artery pressure to adequate levels. And one can place a clip there. And after that, one can close the stent. So here's a situation where we've done a PA band for a left ventricular preparation in a patient with the situs inversus, CCTGA, VSD, and increased pulmonary blood flow. You can see the relationship of the great vessels. This is an anterior lying aorta and a posterior lying pulmonary artery. Here's a situation where the patient had had a bilateral pulmonary artery band. They had truncus arteriosus with the interrupted aortic arch and a large PDA, but the patient had sepsis, and therefore there was a contraindication to put him on cardiopulmonary bypass and do a complete repair. So here's the band on the right pulmonary artery and the band on the left pulmonary artery. So that's all about pulmonary artery bands. Thank you for your attention, and questions are welcome.
Thank you. Thank you, Dr. Iyer. Sir, is there online any questions from the students?
What's your name here? A doctor?
Hmm.
Doctor Avni. Thank you.
Sir, one take-home message for the students, sir. What you would advise for the exams on this topic, Dr. Iyer, sir?
Well, basically, I think for shunts, they should know about the indications for shunt. They should also know a bit about the history of the shunt, which I already mentioned, especially Blaylock, who was Tausig, and who is Thomas. They should know the both advantages and the complications of a shunt, and sizing of the shunt. That's important. Apart from that, likewise for pulmonary artery bands, they should know the current indications for a pulmonary artery band. They should know the Trussler's formula for historical interest, at least the sizing of the band. And so I guess that would be the general questions asked. But if there are any other doubts they want to clear, they can.
Iyer sir, I'm Tendolkar. I want
Yes,
to ask
sir.
question.
You don't have to introduce yourself, sir.
Ah,
I can.
look, about banding, various things you mentioned, you try to achieve one, the other one is not achieved. For example, you try to maintain saturation above 95, then the gradient across the pulmonary artery are not achieved, and vice versa. So which of all these you will give far more importance?
The gradient is what you can achieve as long as the other parameters are maintained. So the gradient is the last thing. If you cannot achieve the gradient, then you come away with a relatively inappropriate band, because it's essential that you have no hemodynamic instability at the end of the band.
So I want to ask you which parameter you will shall just not compromise. Saturation?
All parameters you cannot compromise on saturation. you cannot compromise on heart rate, and you cannot compromise on blood pressure. So all these three have to be maintained. And if you can
In my-
manage to get the optimal gradient,
In our experience, little experience, try to achieve one, the other is not achievable.
yeah, that's
The
what I'm
moment you
saying.
do band, systemic pressure goes up. Then you try to achieve the ideal gradient, saturation falls. That was our persistent problem.
Yeah, so
And under
usually,
anesthesia, 95%.
usually
So-
that happens when there is already some pulmonary vascular disease that has already occurred. Distal PA pressures are high,
Possible.
so you
Because
cannot get the gradient. So
government hospital, you try to get, you not try to get, you usually get patients very
the
late.
patient may be late presenters. So once they're late presenters and the distal PA pressure is high, then your gradient will always be less. You cannot get
Yeah.
a.
Thank you.
Thank you, sir.
Thank you.
One more parameter which you need to look at is EtCO2 on the monitor. If your pulmonary blood flow is extremely reduced, in spite, I mean, having achieved the desired gradient, if you do not get adequate EtCO2 on the monitor, your band is too tight. Around about 35.
It's just a hallmark for sudden cardiac death.
Dr. Iyer, one question for you. What is the present state of port shunt in the PH situation?
So
What is the principle or this thing? How did it get revived?
yes, the principle of the port shunt is that that's an avenue for decompressing the pulmonary artery. And because you're putting it into the descending aorta, the desaturation is only in the lower half of the body. It's not in the upper half of the body. So you decompress the pulmonary artery without affecting systemic saturation. So your brain saturation is not affected. And it's only the lower body saturation that gets affected, which is better tolerated. So
The other thing is take down of the shunt. He is not ready. He is okay. What? Okay. Lower half is ready.
Thank you.
Thank
Thank you, Bolo, yeah.
Thank you, Dr. Iyer,
Thank you,
sir.
Dr.
Thank you so much for joining, sir.
well, thank you.
Yeah. We'll have a short tea break and again be back. The next is important discussion on instruments and CPB, the cannulas. After that, I will be high tea. Now only simple tea. Jagannath so told.
Why don't you?
They should be charged for to answer. No, now it's interactive session for the instruments and cannulas.
Do we have to come?
Jagannath sir.
No. I will bear it. Sir, somebody help us. At the table, hello. Yeah. The table I want here. Full table I want here. With that thing. Yeah, where are the instruments? इधर लेकर आओ रेडी करो सेट
बैड आता है इंग्लिश को भी हमको मालूम है बायोलॉजिकल का नहीं है बायोलॉजिकल वाल का नहीं है बायोलॉजिकल वाल का नहीं है ओ कन्या दूर जाकर मत बैठो ना अभी तुम उधर जयदेवा जाकर बैठो आगे आओ ना सब लोग I haven't understood your basic concept. You come to learn, no? Come to your interest should be far more than our interest. Looks like I am interested. चलो स्टार्ट वो चाय वाले को बोलो आ जाओ अंदर वो जो है नॉट देयर
They don't need to stand. They can stand
या सर उद्यम चेयर आइए पधारो Yeah, I am active in the standing position. चलो any instrument given to you what where will you look always look at the for the serrations correct where is pots you have a pot scissor any scissor
What is it?
medicine bomb so medicine bomb what's your name so any instrument given look at the tip correct so number 2 open the instrument see the serration particularly clamps forceps open the instrument and see the serration transverse serrations or longitudinal serration okay that will tell you what this instrument is and what is the use of this instrument so usually I'm sure Prasanna sir all we one generation of teachers allow the students to pick up the instrument.
Yes.
Don't spend too much intellectual time in choosing the instrument. If you choose simple instrument, we will give one instrument which is typical. Okay, we try to balance because you think you are trying to be over smart than the examiner. Examiner is smarter than you. Understand? So don't try to think, should I choose this or that? Choose any instrument. The examiner is going to give one instrument of his or her choice, which is going to be difficult. Okay, so let us start. Now, can we start?
Sir, when we are saying serrations, we'll finish off the serrations.
Session, so when actually the instrument comes, we'll talk about
Okay.
it. That will be much better. I'm just starting from here, so we don't miss. So simple is quickly tell what the instrument is, and usually it's a way of asking you the operative step. Nobody is going to ask you tungsten is what formula, and this is nobody is going to ask you those things. Guarantee. Somebody is asking either you are 100% filling or
100% full tosser.
Okay, so don't waste time. So quickly tell me what is this? Malleable retractor, sir. Any name you know? Why you think it's malleable? Malleable?
Is it really malleable?
Malleable? Of course, at your force and that boy who ran away just now to Hyderabad, by his force, anything in the world is malleable. But this is not malleable. So you know this name? This is called Ross retract. Ross retract. It is similar to kidney retract. Okay? You have seen this being used? Anybody? Where it is used? In aortic valve surgery. अभी सीधा
Surgery.
बेटा तू ना सिंपल बात कर तुमको ज्यादा मार्क्स मिलेंगे.
When you talk to,
Aortic valve surgery is ask you हो जाता.
I'll ask you that, or I'll ask you aortic valve repair.
So basically what?
Don't get into.
Aortic valve replacement. I have seen being used for aortic valve replacement. For retracting what? Only the aortic wall.
Lower lip.
Understand? Lower lip of the aortic wall. It comes in various breadths. Okay. This part is various breadths and various lengths depending upon the company. It is one full book of Anil Tendolkar, which is circulated on instruments, which contains this. Okay. So more important is to talk. What is the problem with this instrument? By the way, this has got curvature which matches the aortic curvature like this. See this? Okay. So when you are, what is the first incision Prasanna told in the morning? Some student was answering. RCC, NCC junction. So if that is the exactly anterior lip and you try to retract, this instrument is going to come in the way of retracting. Okay. Number two, this instrument doesn't have depth. So many times when you go to the posterior part of the aortic annulus,
Slip.
NCC, LCC, you want a retractor like Langenbeck, which will go into the LV and retract the entire anterior wall of the aorta with the LV. From that point of view, this is bad. If this is not available, what other instrument you use for retracting?
Smaller retractors are the retractors.
Eyelid retractor. What is that? I
Oh,
don't know.
they are referring to this.
This is VSD retractor. Okay, you can use this retractor also. But see the amount of curvature, hardly any. So many times what happens, particularly in teaching hospital, assistant want to see what the boss is doing, whether the boss is doing correctly or not. So what happens when you do like this? This slips out.
Or worse still digs.
Digs. This margin digs into the anterior margin of the aorta. So next question will be asked, how do you excise the aortic wall? Just I'm imagining, okay? So look, she is counting the instruments. You are standing to make sure that I am not pocketing any instrument. Metal detector is kept outside. But this is the instrument kept fantastic. Where have you seen this being used?
AVR.
Apart from AVR.
In our hospital. See, one thing I would like to tell you is tell what you have seen in your hospital.
No, I will know.
No, I'm asking.
Not seen in
No, I'm asking because she's going to end in trouble.
AVR,
Yeah, you can use it in AVR, but what is the thing that's commonly being used in your hospital? VSD.
VSD retractor. Which part of the VSD will not retract with this? The posterior inferior margin where the conduction system goes.
Used
In fact, this is used to retract the anterosuperior margin of the perimembranous VSD. This is the instrument I was talking about. This is the instrument I was talking about. You can use two instruments to retract the small LA. One over here, and retract the small LA. Okay. So other questions will be now what we asked.
And this is also used to retract tricuspid valve.
Okay. So one principle I didn't tell you yesterday. I forgot. Dr. K.M. Chedi's favorite principle that don't try to see the entire VSD. Start taking stitches and the previous stitch acts like a retractor in the direction which you are going. So the next stitch is C. Take a stitch, leave this, now retract this.
This is
so
why
when I fix the sutures of VSD sutures, which I do by interrupted sutures, the first one is not fixed. First one is pulled. When the second one is taken, first one is fixed. When third one is taken, second is like that. You keep on keeping one suture for retraction.
I call it climbing up the VSD.
Very good. Chalo.
I think we can keep it here. Anyway, we're returning it.
Now,
So this is a clamp, a vascular clamp, which has serrations, longitudinal
so
serrations.
many adjectives you can use and you can get full mark. All of you are trying to be constantly in a defensive manner. First she said clamp, then she modified it to vascular clamp. Now further modification into Side biting vascular clamp.
Then it will be.
Then what will be further
Sir,
into
you put it as
Sathyaki clamp.
Side biting vascular.
Sathyaki, this is. Now, any clamp, whenever you are doing anything, use a sequence. Tip
Correct.
the blades, the joint, the handle, the ratchet, and each one of these things you should be able to tell from one point to the other. Then you will not forget anything.
Any vascular clamp, you close and look at the tip. All of you, those who are having vascular forceps,
Forceps, yes.
vascular clamp, close and look at the tip. Look at the tip. Look at the tip. If you see the tip like this is called Sathyaki serrations. And if you have got tip like this, sorry, DeBakey serrations. And this is called Cooley serrations. 2:2. This will have 2:1. So 2 into that 1 or 3
into 2.
4, 3, depending upon the width of the clamp.
And
of
there
the
is
tip.
there is one more.
Understood this?
Yeah. There is one more called Castaneda serrations, which are in Castaneda clamps for your neonatal surgery, which you might have seen when doing switch and all. You have those fine these things which were made by Sathyaki, not by Aldo Castaneda, where see what happened. DeBakey did it like this, whereas Castaneda did it this way, horizontal like this, so that you can make a very thin clamp with vascular serrations.
Sathyaki clamp has got, this is called clamp depth. From here to here is clamp depth. And from here to here is called clamp width. And depending upon the width and depth, you can have variety of sizes of the clamp. Where have you seen this being used? This is standard question pattern. So these are all your homeworks. On your way, you're flying or train? Flying. So when you reach Lucknow, make it a habit. One homework is writing down all the operations you have seen. Whole problem is of articulation. Problem is not of knowledge. Problem is of what you have seen to be written. Otherwise, in the exam, your internal examiner, sorry, this operation yesterday you only saw. Come on, sir, otherwise he's a good boy. But today, because you have come, he is not doing. So who is bad? I have come to Lucknow. I am bad. Otherwise, the boy is good. So this, your boss should not be begging to the external examiner that, sir, otherwise he is good. If he fails, my department will fall down. My department will crack. So avoid, you pass on your own. Understand? So number one homework is write down all the operations you have seen. And every instrument I'm talking, every operation you are talking related to that instrument, you should be able to describe that step of the operation. So where have you seen this being used?
Sir, in proximal.
Why are you taking such a long time? You have not seen this instrument?
I've seen, sir. Proximal anastomosis of the CABG.
So tell the steps of proximal anastomosis of CABG.
Sir, first fashioning the hood of the.
First, you should say that we do proximal anastomosis after completing all the distance. Or vice versa also you can say. That you can say, sir, we first do proximal anastomosis. Number two, what conduit you use for proximal anastomosis? Normally,
So vein or radial?
Reverse Siphanus vein. We don't do proximal on the aorta of radial.
You're doing radial?
Declare karo. If you do it, you say that. If you do it, say that. Tell me the steps. Major steps. Huh? I will take medicine bomb in hand, in right hand. Aisa sab nahi chahiye.
Yes.
Step 1.
So fashioning the hood of the conduit.
Of the vein.
Of the vein. And keeping it.
What do you mean by fashion? Aid line.
Beveling.
Beveling.
You bevel.
You mean beveling.
What is the when you
It is after the distal.
You're doing it.
After finishing the distals.
Yeah. After
So before beveling, what will you do?
What will you do? You put the distal graft Then you take something and then what do you do now?
Check the
Sir, the air
more than lie, length.
length
First
of
is
the
length. Number
length.
2 is lie. This is only place where lie is the correct answer. Is the
Yes.
truth.
How do you check
truthful
what
answer.
are the ways to ensure lie? Manya got scolding last week.
Oh,
We mark before we take the vein out of the leg, as soon as we've isolated, we mark.
You can mark it. Some people will mark it a line
line.
on
So
that.
that is not lie. That is the axial
for
rotation.
distortion.
Axial rotation.
And then how
I am talking about lie.
how do you check for
Length.
lie?
How do you decide the length? Lie will decide the length.
How
So
do you determine length?
you do on pump or off pump?
Off pump.
You do
Off
off
pump.
pump. Advantage from length measurement point of view or
While
disadvantage from length measurement point of view.
so
Advantage. Because the chambers are full.
full.
Those who do on pump, they have to put your hand over pulmonary artery or RA to mimic as if it's a full heart.
What do
Then
you
OM grafts are brought up in a J-shaped manner.
where does
Well,
it go? You see the L, you go down, touch
LV,
the LA appendage and come up
LV graft OM anastomosis to groove
to
and
LA
then,
appendage.
then
up
in the appendage over the main
in
pulmonary artery and then you reach the aorta. Done.
What else are you doing at that point of time? You want to you take the graft and you put it like this, and then what do you do next? You determine
The
location
location of the
and the
proximal anastomosis. Lie also.
again the
length
lie.
and-
How will your anastomosis, whether it will be transverse, will it will be like this?
Chalo. Next step.
Sir,
Remember your lifetime. Cutting of the graft is the last step. There is another step before that.
Before that.
Cutting is the last, remember. Separating aorta and pulmonary artery. Why you forgot that?
Sir, we generally fashion and then to reduce the clamp time.
Reduce the clamp
I
time?
mean,
What is the
there's no
clamp time?
clamp time.
No.
Then we dissect and
How do you clamp? By the way, all vascular clamps, what Prasanna was trying to tell, this is called box. This is called box. And this is ratchet. This is shank. So when you engage each ratchet, a pressure is generated in the jaws. Okay? Scientists have measured the pressure per ratchet. So all vascular clamps, apart from being longitudinal striations, will have a long jaw. So the pressure is distributed over a long area. As against this, a needle holder. I was trying to see whether it's a needle holder. See this needle holder? Very short jaw. So when you lock the ratchet, entire pressure is concentrated at over a small area. So idea is what? The needle should not wobble. Here that is not the idea. Here the idea is what? The vessel should not get damaged. Also, I'm not sure about this clamp, but the straight clamps, if you see, the tip will touch.
It will go
The
serial.
tip will touch, but the central part will be spaced purposefully. So this tip will go beyond the aorta and close, but this will be open. What is the next step after separating aorta and pulmonary artery?
Anything you'll do?
You actually clamp. So what are the things you do before clamping?
see the
Prasanna sir asked in the morning.
yes sir. Feel the aorta.
The modern era epi-aortic probe and decide, particularly in which cases? Elderly, renal failure, on dialysis, redo surgery, calcification elsewhere. Articles have found out higher risk cases for ascending aortic calcification. People do on-table palpation of a soft aorta also.
And see if there is less vasa and
if you see a flat
Flat,
adventitia, more vasa vasorum, high chance of plaque inside. So the examiner tells you, madam, patient is 75-year-old, patient is this. So you understand immediately that patient, the examiner is trying to tell you that possibility of a plaque. Okay, young 50-year-old young patient. Tell me the exact steps.
Sir,
You can give me the mic and
yes,
with your hands you show the steps.
sir, after dissection of the
Say
Then everything.
Graft cut, you want to cut it before cut.
applying
You want which graft? RCA graft or
OM
D1
graft.
D1 graft?
PDF, yeah, I see.
You should know on aorta what are the parking slots of various grafts. You know, if you draw aorta,
RCA graft, where is it going to go? On the
surgeon, thank you. If you say right and left, she will get confused. Again, she will see already seeing like that on the surgeon side. So you try to mimic.
OM
It
graft
is like
low or
this.
diagonal?
Always remember this. It is like this. This goes to LAD diagonal, OM1, OM2, and this goes to RC. This is the aorta. Idea is the grafts don't cross each other. How many punctures? By the way, what instrument you will require? Forceps. With the forceps, you pull the aorta and this
Before
clamp,
you do it, you lower
the pressure, and with this clamp, you go down. Then he's trying to show you this. You have punched. How many holes you will punch? You are doing 3 proximal anastomosis.
3 proximal anastomosis.
You go
Off
check,
pump.
check,
Off
check.
pump. Off pump surgery. I am asking you one at a time. You do 3 or 1.
You make 3 holes.
Why? You are going to put 3.
3.
Are you going to change the position of your clamp? No. That is the whole idea of choosing this clamp. Now, once you clamp, you punch 3 holes. But are you going to punch all 3 together or 1 at a time?
Why?
Sorry?
Let the air with the graft be there. I put bulldog.
Why the clamp should slip? Clamp will not slip. The clamping of aorta creates what? Hemodynamically? Increase after load. So your LV, which is not yet vascularized, sudden increase after load will result in LV distension, bradycardia, hypotension, for which what you will require? Undo what you have done. So what you will do? So if you have punched 5 holes, then like Pasuri, you have to put 5 holes,
5 fingers.
5 fingers on 5 holes and start shouting. But if you have got just 1 hole, control very comfortable. This is standard tricky question that will be asked to you. So on this clamp, proximal anastomosis questions will be, how do you do proximal clamping? And remember all these clamps wrong. Still bleeding? Still bleeding? All of you do what? Prasanna, Simha, head of the department. ऐसा पूरा जोर लगाते हैं.
Cursing me, no?
Cursing me. Each time he gets crushed. He gets a crushing feeling. How is it placed? This way or this way? I am the patient. What is the wrong in this? There is one clamp similar to this called Dera clamp. Dera has got an additional angulation. Otherwise, looks ditto like this. So it is placed this way, easy for surgeon, right hand. But this comes in the way of the surgeon. So you put it on the patient's neck side. So what are the types of movements of this clamp? 2 movements. One is front back and another is side to side. So you ask your assistant to hold or you fix with gauze piece. we ask our assistant to hold. So this movement, this, and assistant keeps the hand on the surgeon patient's neck. So this prevents side to side, and this thumb pressed against this finger prevents front to back movement. Okay, enough of this today.
And incidentally, you are going to a new center, and you are asked, please test this, check this clamp. How are you going to check? You're going to buy the clamp. 5 companies come. Yeah, you can place it like this. This should not cause pain. You see, no? She's looking at me very. You can try. I'm not going to harm you.
Don't believe him.
Is it paining? No. If it pains, it's a bad clamp.
Or I thought gloves. You can put it on your glove.
And another thing that I can ask you is, you are in a rural setting, or you are a new cardiac surgeon, and you have got a patient who has had a uterine bleed, massive uterine bleeding. You have been called to ligate the internal iliac artery. You don't have all these clamps in that hospital. What are you going to do in that case? You don't have any vascular clamp. No, this is a practical problem when you are going to tier 3. You all have to go to tier 3 and B, C cities, and there is a patient bleeding or a bulgur injury, and they say, and you have no vascular clamp. What are you going to do? No tape.
Rubber shorts.
So what you have to do is, not even rubber shorts. No, the thing is that you take the and put a video in Google. You can put the name. What you can do is you can take the glove, rubber glove, cut it on rubber band, and put it on this. And the same test you do, put it and this thing. Don't crush it. Instead, do this test that it lies in place with the rubber band. So now this is a band which can, and this has been described in the older books before vascular clamps were available by what is it, Nobel Prize, Alexis Carrel, and you can put it and you can place it
Rubber band
here on this hand, and I've actually put a video on how to do it in around 11 years back on YouTube.
We put rubber shorts on this
the
full.
rubber short will, but the pressure created by
Pressure
this
created.
is too much.
Sorry, sir. Which instrument?
No, I took it from there.
Okay. Chalo. Instrument I don't know.
Yeah, this
Prasanna knows this. You may not have used it.
it is a very peculiar thing.
This is from your institute. कौन सर का institute का कौन है? सर का institute का ना?
What is this?
See, in a practical exam, the number of seconds he's taking and the way he's looking at it. Huh? Or somebody from deserts start looking at a girl. कैसा लिखते हैं मालूम पड़ता है कि कभी जिंदगी में नहीं देखा है.
There in our hospital also. This is not our hospital instrument, but
Anyway.
this is used in a lot of places. This is the Dennis Brown PDA dissector. What is the beauty of this dissector? It is a bulbous tip.
No, I will.
Yeah. Can you see? Can you see here? It has got a bulbous tip. So when you dissect a duct, you don't poke and make a hole in it. This was described by Dennis Brown. You know Dennis Brown, pyloroplasty, Dennis Brown. Same guy he did something here, he did something here. And this is to dissect the duct. It is available both as a slightly curved one and one to loop angle, like a right angle. And the beauty of this is that when you are going under the duct, you will not tend to tear the posterior wall of the duct. So this was designed for that.
How do you identify duct? Have you seen ductal closure? We have to ask this question now. Otherwise, that was a standard first operation, early operations when we were residents. So how do you identify a duct? Left thoracotomy, left posterior lateral thoracotomy, left, Left.
No, he should say left.
Left.
Lies in line with the main pulmonary artery.
No.
Left thoracotomy, you see main pulmonary artery? काय पडतोय रे बाबा? Left thoracotomy, you retract the lung anteriorly. What structure you see? Descending thoracic aorta and the mediastinum. If you look up, what will you see? Left subclavian artery. Now you on these landmarks, you tell me, duct is here. One is thrill. Anything else? People have closed intercostal artery, clipped intercostal artery, and then echo shows ductus still patent. Understand? So you must know where is ductus. Ductus is exactly opposite to the left subclavian artery on the inside of the arch. So you cut the mediastinal pleura on the descending aorta, retract it anteriorly, and opposite to left subclavian artery on the inside of the arch, you go. Any other thing? Around the ductus, anatomy. The vagus will send one recurrent laryngeal.
Right recurrent.
Right recurrent laryngeal, no? आज क्या आज राइट एंड लेफ्ट का क्या लफड़ा चल रहा है यार? मैंने सबके मन में कंफ्यूजन किया है. क्या है? Right? Sorry. Left recurrent laryngeal nerve. So these are the two important structures. And at the junction of the ductus, the aorta becomes bulbous. Okay? So these are the 2 or 3 important, and you are supposed to dissect first posteriorly, then superiorly, and then anteriorly. Most of the students tear ductus, including me, because we are in a hurry to loop the ductus. Don't be in a hurry to loop the ductus. Go posteriorly, then you go superiorly, and then you again come anteriorly.
And in some institutes, they do again here ligation by subtraction. Be aware, I don't know whether what is practice, but in some institutes, what they do is don't directly loop the ductus. They loop above, they loop below, then pass it. And another thing is, many examiners want you to tell that I will loop the aorta above.
I was about to say, all old-time examiners will insist on looping the arch first. They will ask you ductus dissection after mediastinal cutting. If you come to ductus straight away, the olden days, we were told over. First is loop arch for any proximal control. Okay? And how the dissection is helped?
What is done?
Helped by controlled hypotension. Why are you so quiet? If you say you have done, he says he has done. You are not ligated, divided, nothing. Initially you said I have seen. No, so changing times. Okay. Okay. Chalo. A water, there is a pericardial lappet which comes along the superior margin of ductus. And while dissecting many times, it breaks. And what will come out from pericardial lappet?
What will come out?
Pericardial fluid. Watery fluid will come out. So don't get scared. It's part and parcel. And while taking a bite, take a generous bite, both the sides. With the help of usually with the help of a coolie clamp. Ductus, what is the shape of a ductus normally? Cone shape. It is broad at the aortic end and narrow at the pulmonary end. So at pulmonary end, you can put a mixture, vascular mixture. But aortic end, always a small Satinsky or a coolie. Okay? There are, by the way, official ductal clamps. Long, straight clamps. So they put on 2 sides, dissection and cutting. And what is the current technique of ductus closure? Surgical closure? Ductus closure? Clip. So don't have to go around the ductus. So dissect superiorly, dissect inferiorly.
Put a big clip.
How do you decide the length of the clip? Which end to clip first? The aortic end should be clipped first. How do you decide the length of the clip? Diameter of the PDA. Excellent. Diameter of PDA 3 millimeter. Why? Why 4 and 5?
Length of the PDA is.
Many of us confuse. Diameter 3. When the circle becomes chapta,
2 pi r.
It will be pi d divided by 2. Understand? And then you have to be little extra in length. So 3 millimeter is the diameter. So circumference is 9.3 pi d divided by 2. So it's going to be 4 point,
So you need
more than 4.5. Understood? So this calculation has to be kept in mind.
This is a DeBakey forceps, sir. Atraumatic forceps. It's used to hold tissue, RA or
Why
pericardium.
you say it's the DeBakey forceps?
It is atraumatic. It is
Why you say atraumatic?
the longitudinal serrations.
DeBakey serration.
DeBakey serrations.
Longitudinal vascular serration.
Serrations.
Why this part is rough?
For grip.
For grip, always it will be some sort of roughening. So body fluids, saline, serum, don't make it lubricated and doesn't slip. Very good. Now, depending upon the tip, it can be various diameter tips.
Yes.
Okay, 2 millimeter, 3 millimeter, any varieties of tips.
Yes.
In our municipal hospital, I don't know currently what they have done. We have made it a rule that all forceps should be DeBakey forceps. No tooth forceps, no cross section forceps, because our nurses keep on changing every month. And moment we praise one nurse, she's a very good nurse, we tell the matron, tomorrow morning she is shifted to psychiatric OPD or diabetic. So they think that Tendolkar praising, that means Tendolkar has fallen in love with her. No jokes. Okay, second forceps.
Angled avascular forceps used for Lima.
Memory. Why Lima? For Lima?
Lima or Rima. Memory.
For memory
harvesting.
What is the advantage?
It does not come in the vision, sir, when we are retracting.
So which part of the memory pedicle you will hold?
We will not hold the pedicle.
So if at all you are asked to hold, initially for few millimeters, you have to hold the pedicle.
Yes.
So where you hold?
The surrounding tissue.
Thank you. So why are you taking such a long
Okay.
time to say
Yes. Yes.
surrounding tissue? So you never,
Hold the
you shall never ever go near the memory.
Yes.
What are the various tricks you do to avoid injury to memory?
Mm-hmm.
One you have already told. You hold it, the pedicle, rather than reaching the memory.
Yes.
Two,
You
cautery setting.
lowest
Low, how much low is low?
20.
10.
So it's a auction, you know.
10.
15, sir, 10. Okay, any other instrument you know?
Any other thing that can
Any instrument you know used in India? Many people, harmonic.
Okay, harmonic scalpel.
Or else even if they don't have a harmonic scalpel, any other thing to help. Bipolar can be used because you don't arc the
Cautery current.
Yes.
It is less than 10.
10.
That. Okay.
Yes.
Anything about the clips? Many surgeons nowadays clip both ends of the branches and cut the branch with a scissor to avoid any heat, thermal injury. Third is, while cauterizing, make sure your cautery doesn't come near any clip. So the clip, the current can pass and damage the memory artery. Some people pass a saline
carbodissection or hydrodissection
for separation. So chance of coming near decreases. Okay? Very good. Chalo. We have already discussed with this. See this jaw? See the length of the jaw? And see the box? The length of the jaw and the shank are equal. So the force you generate is not multiplied over here. In needle holder, see the length of the jaw and the shank ratio. So here the pressure will be not only concentrated, will be multiplied. See here it is equal. Now you just close so the tip touches. Now see the space in the middle. Can you see that? So yes, where have you seen it being used?
So this is a vascular cross clamp. We can use it.
Not stop this word, we can use it.
So it is used.
This is not a surgeon's manual. I will use. I have used. In practical exam, everything is to be I will, I shall.
I have used it.
As I always tell, for practical exam, Kirkland, Barrett boys, Sebastian, everybody should be sent to Switzerland on a paid holiday. And constantly, Prasanna, Srikrishna is asking you, what you in your institute? Constantly we are telling you your
Let it be
institute.
clear, we are asking your institute because we want you to be able to tell what have you seen. We want to know whether you worked.
It is used to.
So where
I
have you
use
used this?
I use it to cross clamp the aorta before.
Fantastic. Exactly the answer you have given. I wanted you to describe the steps for cross clamping aorta
So
at your centers.
in our center, after we establish the bypass, means the aorta
Full cardiopulmonary bypass.
is
And yesterday I told you what will you check when the bypass is full. What will you check?
the pressure, the distinction.
Where is the tube gone?
MPA,
Where is the tube gone?
the MPA.
I can put sucker. I can put sucker on some part.
I am kinder. This is better.
So the RA and the MPA.
Bhattacharya sir, aapka kya hai? You, why are you bothered about what anesthetist will check? Idhar kari Parimala left. Discussed. Huh?
So I'll check the RA and the MPA.
RA should be empty. MPA should be
soft.
empty. If MPA is full, you will put a left heart vent.
Yes.
Or so mitral valve case, I just stab and tell my assistant to keep hands away. The assistant moment sees blood, wants to put sucker and chuk. No.
They should be pulled.
Okay?
Yes. And then after that, I make a space between the aorta and the MPA. And then I pass a umbilical tape or any sort of vascular tape around.
I pass
an umbilical
You routinely tape in your institute?
Umbilical tape we take.
You routinely tape
Yes.
the aorta. Okay.
Yes.
Not, if you do
Many
fine.
institute, JJ Hospital, I don't know whether you know JJ Hospital.
ZZ. I did
JJ Hospital, one of the oldest hospital after perhaps government hospital Chennai. One of the
Calcutta,
oldest, Calcutta.
Calcutta and then
Okay.
JJ.
JJ, 200 years old. First step before any bypass is Yandre, Anna.
In some institute, like in JJ?
It's called go around. And before taking any posting, aorta, you go around. Okay, done.
And
Next.
then after that.
Actually, go around is not required. Just separating aorta from pulmonary
PA. Or
artery
else some
is
people,
enough.
some people.
Which cases Anil Tendolkar who doesn't go around will go around when aorta is large.
And in which
You
case,
saw Bentall.
which
or
cases where
ascending
you
aortic aneurysm
see,
or AR.
which
I'm
cases
not
where
sure what forces will pick
see
up.
many cases we don't need to even dissect the aorta from the pulmonary artery. We will just pinch and place it and put it. But in where will you mandatorily dissect between the aorta and the pulmonary artery? For example, ASDs in my hospital, we don't dissect. The less we dissect, the less chance of injuring something. But which case where you will dissect between the aorta and the pulmonary artery? AVR also not really required. What is that where you mandatorily?
Durga. Proximal anastomosis.
1, 2.
Just now we said no dilated.
Yeah. Then
if you want to do
something where you have to mandatorily do it. You even with this thing, I can clamp and they somehow manage. Here I can clamp and I cannot manage.
What epi window?
No, anything where you are going to operate on the pulmonary artery. When you're going to do a pulmonary valvotomy, open the pulmonary tetralogy,
Outflow patch,
patching, anything.
RPS stenosis.
A pulmonary endarterectomy.
Okay, done. Next.
Then after that we can I pass my index finger or a finger around and I can place the cross clamp. In a
Oh, index finger for what? Protecting.
means thoda sa approximate ho jata hai.
Okay. So you pull the aorta up, but you have looped the aorta, no? So why don't you?
No, if you put the umbilical tape, some people pull it.
So after
and
putting
fix
umbilical
it.
tape, why use finger here?
Yeah.
Unless you enjoy putting fingers.
And then what do you do? Just take and put the clamp on. And
stop the flow.
Reduce the flow.
How?
Many centers do not cross clamp unless a temperature, particular lower temperature is reached. So you should be ready with all these things. Examiner will ask you, oh, doctor, will you wait for 32 degrees centigrade? Immediately your eyeballs will go right upper quadrant and you start thinking. Immediately we come to know that this boy has not thought about this possibility. So you must know every step. What is the prerequisite at your center? You declare. Aortic cannulation. You declare. We don't bother about the ACT.
Brother, we will.
ACT will come up by the time my resident starts cannulating. My resident takes 15 minutes to cannulate. So ACT what? ACT will reach 9999 by that time. So you can say that, but you tell it on your own. This is so there are many centers who wait for LV contractility to decrease. Otherwise, what happens? Close aorta and LV is beating. LV becomes empty. So LV starts enjoying. Heart rates become slow. Frank Starling's law. LV fills up more, enjoying more, contracting more. So many people wait. Some people even fibrillate the heart and then cross clamp the aorta. And after cross clamping, what will you check? See, you have started thinking.
Every day you are clamping, no? You clamp the aorta.
What things can get clamped in that aortic cannula? Okay, accidentally it can get clamped even in this also.
Ratchet or a disc.
Okay, previously when we were resident, this clamp was straight. We did not have angled DeBakey clamp. We had straight clamp. So what will happen because of that? Come in the way. Otherwise, clamping was good. That is, clamp is still used for descending thoracic aorta. So this clamp sits like this. So this ratchet can clamp aortic cannula, the body of the aortic cannula. So you will make sure, and you will ask whom? You will ask the perfusionist, assistant. You'll ask the perfusionist, check resistance. This can take the tip of the aortic cannula. Improperly.
Or it can even, when you are clamping, it can push and kink
yesterday
it.
we discussed, you clamp, give cardioplegia, heart stops, heart comes back after 13-14 seconds. It comes back means what? It just starts moving this kind of movement. Video band hai na?
No, it's going on.
So
Incomplete
clamp, what will you do?
We'll have to reposition the clamp. So
We'll remove the clamp.
No, sir. First we'll put the floats down. We'll put another clamp and then we'll remove this clamp.
With this clamp on or not?
With this clamp on.
Where? Distally or proximally?
Proximally.
If there is a space, ideally proximally. If there is a space available between this clamp and aortic cannula. Otherwise, you will be full. If you have opened the aorta, please put a clamp distal to. Don't try to put proximally. How do you remove the cross clamp? This is applying cross clamp. Your steps for removing the cross clamp, your steps. All cannulae, how do you put? How do you remove? All clamp, how do you put? How do you remove? Same thing about your partial clamp also. Before removal, what you do?
What do you do for removing the clamp?
Through the cardioplegia line, we can ask for
de-airing.
So de-airing, I will ensure complete de-airing. Number 2.
Once de-airing is done, gradual removal of
You just remove.
And
declare?
Don't you inform someone?
Yeah.
Inform
the perfusion there.
Why?
Because the flows will be.
No, what command do you give at that time? You just say, clamp off. Is it?
Flows down.
Why that flows down?
Because there will be a sudden increase in blood flow across the.
So aorta is strong, no?
Perfusionist is watching WhatsApp. He will not flow down. You say flow down, he'll say flow.
In an empty aorta, aortic leaflet may not be competent. So when you suddenly the gush comes, the leaflet will not have time to coapt. So all this blood will go into LV and LV will distend. So you ask them to come down, remove the cross clamp and tell them slowly increase.
The other reason is that when you suddenly release it, there is a sudden shear stress against the aorta, which is partially opening and it can initiate a dissection.
Yes, sir.
Yeah.
And
All that you have to tell.
carotid differential.
All you have to answer. Not patient. Flight. So nice question, you know. See, only Tendolkar's flight is 7:30, 9:30. And everybody's flight is early. Kya na insafi hai? Okay, what can I say?
Bye-bye.
Bye-bye. See you, take care.
Right angle, sir. Right angle.
Right angle mixture. Where will you look? Tip. Open the tip.
Yes, sir.
What you see?
So
Something
transverse
very
serrations.
dangerous is seen.
Okay.
Transverse serrations.
Transverse serration. So this clamp should not be used for clamping any blood vessel
You have vascular mixture also available.
with longitudinal serration. So always open it and see.
Check.
That's why I told you in our
Especially if you go
hospital,
to a new.
all instruments are vascular instrument. No discussion. So mixture developed it for what?
So to create
What did
aorta,
they make it
aorta
for?
pulmonary window, sir.
No.
Aorta pulmonary window.
To create space between
No.
the aorta and main
He was
pulmonary
not-
artery.
Mixer was a general surgeon
Surgeon, abdominal.
working in war, trying to suture blood vessel injuries. So he wanted an instrument to go around femoral artery, axillary artery.
This was
cuboidal
first done for a
artery.
gallbladder. Huh? Then he used it for other things, like tying
Understand?
arteries,
So it is for
pneumonectomy,
that.
lobectomy.
So you will be asked.
And one
Going
important
around.
question that is asked with the mixture, and this is described by mixture himself, is how do you pass the mixture around a vessel? The most important thing is that when you cross, you have to see the tip. You must never try to, if there is a vessel, and he is described in his own description, you are never supposed to lift the mixture up to loop like this. That is how you will damage the posterior.
I was telling about PDA. You just go inferiorly, then posteriorly, and this
You should see the tip and then
dissect. Okay.
And they can ask you about dissection of a vessel.
Or chalo.
In fact, Dr. Bhattacharya used to teach
Self-retaining retractor.
the Fortis.
Self-official name, self-retaining retractor. And there are varieties of blades. This blade is like a prawns, interdigitating prawn. And the book which I have given you has got various names. You always remember while reading. After reading is over, you tend to forget. Okay. So where have you seen this being used?
I used for femoral artery then
Femoral artery cannulation.
cannulation, popliteal
So
artery
you will be
repair.
asked femoral artery cannulation.
Yes, sir.
Can you tell me the relation of, sir is wanting to ask you.
Mastoid. Yes, sir. Don't know, sir.
Whitlander.
Whitlander. Okay.
Whitlander, I think. Lander. Whitlander.
Femoral.
Relation of artery, vein, nerve.
From medial to lateral band structures, vein, artery, nerve, sir.
Very
In
good.
femoral.
And suppose femoral artery not reachable, cannot find, blocked. How will you reach femoral artery? Easiest is femoral artery palpable, you go on dissecting
Yes,
towards
sir.
femoral artery. Femoral artery is blocked.
Vein I can find, sir, by dissection.
Femoral vein. Any other vein is easy to find.
What is
Saphenous
it?
vein.
The
Saphenous vein is
Vein.
easy to find.
Okay.
Trace the saphenous vein. It will reach femoral
Femoral
vein.
vein.
And from femoral vein, you go to femoral artery.
Okay, sir.
Okay. So remember, what are the branches you will cut? Will be a notorious question. Will be asked. Pudendal, etc. Lateral circumflex. You know, don't know. Quickly. Okay.
sir.
Thank you. Chalo. Give it back. Any instrument you have got? No instrument? Last instrument? Loud.
Metzenbaum curved scissors.
Any scissor, look at the tip. And the tip could be
Blunt or sharp.
blunt or sharp. So what are the permutation combination? Sharp, 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 blunt, blunt, blunt. So this is what? Open. That means you're not open only.
Sharp.
This is not sharp.
Blunt, sir. The tip is blunt.
Medicine bomb is classical blunt.
Yes, sir. Blunt and blunt.
So blunt means what? For what?
Dissection of the. Yes.
Cardiac surgeons are biggest thieves in the world. Thieves. God created mammary artery for supplying chest wall. We stole it and put it on the mammary. Who invented medicine bomb? Medicine bomb. For what? Oropharyngeal surgery. We stole it. Castrofio. Who was Castrofio?
Ophthalmologist.
Ophthalmic surgeon doing corneal surgery. We stole it from him. We have not created any instrument. Dr. Bhattacharya will object to that statement. But sorry.
Hagar, then next one is Hagar's dilator was used.
So no. Medicine bomb. Again coming back. Again coming back. See the distance of the shaft and the blade. Long shaft and small blade. So when you open it, how much? 3 inch.
It will open only.
It will open only 1 inch. So tomorrow you see the pots from that point of view. Pots has a long shaft. So if you open pot this much, the mouth will open only. Understand? So this is the concept. Then you must mention about the length of every scissor.
And then curved on the flat, curved on the
Curved
side.
flat, curved on the side or straight. So this is curved.
Curved on the flat.
Curved on the flat. Scissor could be curved like this, like pots. Okay? Or scissor could be straight. So this is typically, let's see the length. This is classic, some 6.5 inch length. So this is not for
deep dissection.
Deep dissection or doing something to do with mitral valve. This is for pericardial cutting. When you will open the pericardium with medicine bomb?
When do you open?
See, what are you all doing? Preventing blocking is temporoparietal lobe. He's trying to stimulate his temporoparietal lobe, which he has not used in last 48 hours. It has undergone disuse atrophy. You are from Narayan Rudalaya?
No.
And you did not present a single case? First day. First case. First year. So you should ask anatomy to him. So he has seen chest being opened or not?
It's better.
So when you have got adhesions inside. So when will you suspect adhesions inside? One, from the history. But looking at the pericardium, adhesions inside.
Acute condition, inflammatory condition.
Acute inflammatory conditions, why you will be doing operation?
Endocarditis. You think that
You are trying to open the pericardium and pericardium not opening. Your normal judgment, moment you touch the cautery, pericardium opens and what comes out?
Fluid comes.
Pericardial fluid comes on. When you're doing, kya yaar? Scratching, not opening, suspect intrapericardial adhesions. Okay? Young patient with, is not very wrong. Young patient with rheumatic heart disease, multivalvular affection, suspect additional pericardial adhesions. Chalo, let us come to the last one which I seen. Maaf karega. Valve. This is what I want you all to know. Most of you don't know. What are the parts of this valve measurer? You can keep it up so everyone can see.
So this is the cylindrical side.
This is the cylinder. All are sizers. So what is he showing you? That is called cylinder. This is should be passed first. What does the cylinder tell you? Interannular distance. Okay. What is the other end? This is called, hold it up. No, the Vaisa, it looks like a hat. And what is that? That is a supraannular sizer. So first you pass the cylinder. It tells you the interannular distance. Say 25. So what is the next step? To give 25 size supraannular measurer. This tells you whether after the valve fits in, the coronaries will get obstructed or will not get obstructed. This is for mechanical valve. And third measurer is available, what is called replica. Today, Dr. Bashi's video, he was measuring the wall.
For a
That is
bypass.
called replica. That is typically for biological wall. What is the difference between replica and a model? Anil Tendolkar's replica will be 5 feet 10 inches. My weight, abdominal curvature, ditto, 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 ditto. So Madame Toussaint is what? Replica. While you go to Agra, कौन आगरा वाले कौन है? आगरा से कौन सुबह बोला मैं आगरा वाला हूं, गया फ्लाइट पकड़ के. All students have caught earlier flights, and Tendulkar is catching 9:30 flight. Unfair. Go to Agra to Taj Mahal, they give you small things. What are those? Model. If replica of Taj Mahal, Ayya, you will be Shah Jahan. You will require one Mumtaz Mahal to produce a replica of Taj Mahal. Understood? So replica tells you not only whether the valve will fit, not only the ostia will block or not, whether the aorta will be accommodated that valve. So what are the order of giving? First, cylinder. And it is always malleable. And you are supposed to pass end on. Never try to pass sideways. Always pass end on. So depending upon that, you ask for supraannular. And in case of biological valve, you ask for replica. Most important, this is which company? So all valves, only one? No. Every model will have a different valve measurer, valve sizes.
You can't use one for the other.
So ये भी सेंट जुड़ता है, सुबह एक सेंट जुड़ डाला, उसका ही ले दो. No. If unless it is the same model. So keep this in mind. Okay?
This is for only aortic position that we are talking.
No, mitral also same thing.
Same thing will be there.
Same thing mitral. Only mitral, supraannular, you need not pass to find out whether it is obstructing coronary artery. But replica, certainly you have to pass to be sure that LV is accommodating those struts. Okay? Over?
Yeah.
Sir, over? Time I to? Chalo, cannula. Fatapat open karo.
Tell come.
Chalo, those who did not touch cannula as instrument, we touch cannula. Yeah, bada. You enjoyed lunch. Chalo, enjoyed cannula. You had a post-lunch sleep also. All observing.
Come take.
Camera was observing you.
High maintenance, these boys are. Very high maintenance.
Give me one cannula.
You.
Simple cannula. My time cannula. My time cannula. One more cannula. Allowed to open? Sir. Open, check to.
Take.
Panelist, sir. Dr. Sampath Kumar, you are there. Video on, please. Sir, you are there, sir, on board. Dr. Sampath Kumar, sir.
I am.
We can't see you, sir. Kindly put the video on. Sir is there, sir is there. Yeah.
So let us go quickly to all the cannulae as usual for all instruments like cannulae. Look at the tip. Any other standard cannula? Standard cannula.
Gives that other one.
Give. Throw, please. No arterial cannula, standard cannula. No straight cannula. Give.
That is there.
She's so happy that her cannula I have taken away. Always cannula given to you. Look at the tip. Tip has got multiple holes, venous cannula. Tip has got single hole like this one, arterial cannula. Okay, this you say in your mind, like him, don't start explaining. Sir, because this cannula tip has got multiple holes, I will, don't say. Cannula tip could be plastic, could be metal. Cannula tip could be straight, could be curved. So what is the full name of this cannula? Curved metal venous cannula. Understood? What is the full name of this cannula? Plastic tip straight venous cannula. Plastic tip straight arterial cannula. Understood? Everybody understood the tip? Why you make the tip metal? For better ID-OD ratio. Because metal being hard in the thinner wall, thinner wall, it can give good rigidity without compromising ID-OD ratio. While plastic, see this thickness, amount of thickness. Okay, you know ID-OD ratio?
Poisson's law.
Internal diameter to outer diameter. What is relation between flow and diameter?
No.
It must be proportional.
Something, Poisson's law.
Again, not under the table.
Poisson's law, fourth power of the radius.
Fourth power. Okay, fourth power of the diameter, the blood flow changes. Okay, so now let us come. This is name of this cannula.
Main metal tip.
Name of the cannula.
DLPY. Sorry, the DLP. Sorry.
This is the standard mistake. DLP is the name of the company. Name of the cannula.
Pacifico cannula.
Okay. Pacifico design cannula.
Pacifico is the cardiac surgeon.
Cardiac surgeon. He wanted to do pediatric operations on bypass without circulatory arrest. To have a better ID-OD ratio, he developed this plastic tip right angle cannula. Okay. Metal tip right angle cannula. The metal tip has got multiple side holes.
Why?
For draining.
Why?
Draining side branches. Like example, azygous, left innominate vein, hepatic vein.
Why is the azygous drainage important? So what? We can ligate the azygous so many times. No, but why is the azygous vein important in a mitral valve replacement, for example? It is the vein which will take the bronchial return. So now if you are getting flooding and excess LA return on bypass, please check the SVC cannula. Obstructing the azygous. If there is obstruction of the hepatic vein, what will happen? RA will be full. Venous reservoir level will come down.
This is body. This body is reinforced wire body. Advantage?
Not rigid.
No kink. So mostly arterial cannulae are not wire reinforced. But venous cannulae, you keep on moving or in various positions for various anastomosis. Okay?
Yes.
Size of the cannula?
22 French.
So what is French?
2/3 of the internal diameter, sir.
Not 2/3.
What is French? 23. What is 23 in this?
Internal diameter.
यहाँ से कूदो और जान दे दो.
Arey, what is it?
23 is the circumference. Pi d. And we being clinician, value of pi is 3. So 28, that means divided by pi will be what? 7 millimeter. Okay. What is this blue line for? Direction of the tip of the cannula. So all cannulae will have such lines to tell you the direction of the tip of the cannula.
Some will be
now others will not speak. SVC cannula or IVC cannula. Thank you. Many students say SVC cannula or IVC cannula, depending upon the size of SVC or IVC. When SVC is as big as IVC, IVC interruption and continuing through azygous
Azygous, sir.
or hemiazygous into SVC. Okay. Standard question will be what? After this cannula, how do you cannulate SVC or IVC? So as I told you, your homework should be write it down these steps. ऐसा मत उबासी दे बेटा. हम लोग पूरा दिन में एक बार भी उबासी नहीं दिया. तुम कुछ बड़बड़ कर रहे थे, हम लोग सब बर्दाश्त किए. दिन के अंत में आपने जो हमें वाहवा दी है, उबासी नहीं करो. क्या करने का? एक पेन नीचे गिराने का और पेन उठाते समय उबासी देने का.
Ubasi means yawn.
Yawn.
Oh, I didn't know that.
He's yawning. You.
I know, no, I have seen him. He was having the days.
Okay. This cannula, straight, metal tip.
Plastic. Plastic. What else is there? What is peculiar about this?
All plastic cannulae will have these markers. All straight cannulae, I'm sorry. All straight cannulae will have these markers. See this marker? Whole idea is don't press and check it. From outside only you can make out. And this is like maybe 1, 2, 3, then bigger. Then one big, one small, like that. Usually, not over here. Okay? You have used this? Very good. Cannula has been passed. Next step.
First string tight.
In the aorta. Okay, tighten the first string.
Next
Done.
one.
You hold a mic.
We tighten.
Tighten first string, tight the first string.
First string,
I'm only interested in this here.
we take out the stylus after clamp. We gradually withdraw the stylus.
Withdraw.
Yes, sir. And
How many?
Withdraw.
and let the blood.
Do this. No.
Okay.
I'm holding.
So we withdraw this thing.
How much will you withdraw?
Let it come out of the reinforced part.
Up to where? Okay.
And then
Unreinforced part.
Unreinforced part. And then clamp it.
Excellent. Excellent. So this many students say they remove like this. No. This you will pull out. This is a hemostatic stylus. So this will not cause any blood loss. Okay. So till it comes, now you clamp. After clamp, you remove this together.
And how do you remove it? You have to compress this blue thing. Only then it will come out.
Being a straight cannula, yesterday we discussed the danger of going to one of the function is over. The way you are standing looks like. Nahi? Tum bolo. You are waiting for high tea. Good. So you will be asked about femoral cannulation. What are the different techniques of femoral cannulation?
Sir, Seldinger technique.
Open technique,
Open.
close technique. And in between,
There's a
open Seldinger technique. Can you do it? This cannula by Seldinger technique? Without seeing what, how can you say no?
Why?
Without saying, how can you say no?
Sir, because
You are correct, but
You are
without
correct,
saying,
but
how can you say no?
because it needs a guide by its side.
So
What
you
is that?
care.
There is a obturator without a...
See, do you have a hole over here?
Hole.
No. I say, no, confidently, but pull here. What is the fourth technique of femoral cannulation? Done in ECMO? So a side graft. Don't say PTFE. Could be Dacron.
Dacron. In fact,
So-
many places they do.
So to a side graft. Advantage?
It preserves the distal perfusion also.
Very good. Maintains the distal perfusion. Well, हा कॅनोला माहिती आहे? तर ओपन कर. आणि त्याचं पूर्ण नाव काय ते सांग. सर आपका सुबह से 2 दिन से आपकी आवाज ही नहीं सुनी.
He was always backseat driver.
Now the way you are looking now, it immediately tells me that he has not seen it, isn't it?
You have not seen this? Then what is it?
Name of the cannula?
Two-stage
Two-stage.
What?
venous cannula.
The blanks.
So venous cannula.
Two-stage
Venous cannula. So we
What are the two stages? Shh. Wait, dur.
We are all experts.
ये हीरो किधर गया? क्या तुम्हारा in charge of resident? Oh, he has not come. Ah, mother not well. Fantastic. Shravan Bad हो गए सब लोग. Yes, where are the two stages? Whole idea was to give you a chance to think.
Two stages. Where are the two stages?
चलो तुम बोलो.
1 here and 1 here.
What is that 1 here and 1 here?
SVC and RA.
Hey, SVC.
So RA.
So that is called as the atrial basket and the IVC. IVC
and RA.
RA.
Not IVC and SVC.
IVC.
and RA. The cannula is passed from RA appendage. SVC is north and IVC is south. So one cannula can't go both sides. Understand?
Why is there parallel line? There are some parallel lines there, no?
See these two cross lines. So what are they? Sorry? Yeah. So where those lines should be? At the level of purse string. Whole concept is without touching the heart, you should get all the information.
There is one.
How do you pass this cannula? You can keep this down.
Mic down and
you can look at the camera. You look at the camera and show them. Stand and show them.
How do you hold it?
You are the surgeon. What is your name? Sharad is the head end, anesthetist. And Manya. Manya is the foot end. See, looking at you. Where is the IVC? Where is the IVC? To your right thigh or left thigh? Right thigh.
Okay.
Very good.
He's spread out. How is?
He's starting from here.
Now, how do you hold it? What is the recommended way of holding it?
So, what is this then
there for? Do you hold it like this and stab? And then
you pass from RA appendage. So, how do you open the RA appendage?
I from AV group.
What AV group?
Where do you place
the base of the RA appendage? You take a first then ask the one vascular forceps to the assistant, one vascular forceps to you. You open the RA appendage. Usually with a scissor, you cut it. What is inside the RA appendage?
What is there?
Multiple trabecular. It prevent insertion. So what you do? You pass a scissor and dilate. One. Any other technique? Anybody?
Any other method? You can put
side clamp. Cut. And then purse string. So no chance of purse string cutting. Scissor cutting the purse string. Now there are two techniques. If you're holding in right hand, it has to go like this. Last time Dr. Balaram was he said no. I hold it with left hand and pass it like that. Usually the surgeon, right-handed surgeons, maneuvering hand is right. Understand? And steady hand is the left. So you pass it like this.
Do you know
any venous cannula, this or this. Let us say this. How do you know your cannula is in venous cavity?
How will you know?
Sorry? Color of the blood, we are suspecting it is in the aorta?
What is a peculiar feature?
Sorry? Reda is answering. There will be a blood equal to, height equal to CVP. See, simple answers. CVP. And what will happen to that column? Like a CVP column? Swing with respiration. You have
He's not
brain
he's nodding.
With respiration. So go up with inspiration or go down with
inspiration.
Sir, I think we can
No,
stop.
positive pressure ventilation.
Yeah, we are done.
Sorry, over?
Yeah.
Over?
Yes, sir.
Chai has come?
Yes.
Chalo.
Then few concluding remarks.
Concluding remarks?
Yeah.
Thank you very much.
Thank you, sir.
Thank you for bearing us.
Yeah. At the outset, let me thank. Okay.
Is the full name of this cannula.
Full name.
Full name. You tell the full name and over. No discussion. Okay, half name, quarter name. Retrograde, coronary sinus, cardioplegia, cannula.
Anything else?
Any other adjective? Anybody? Siddharth? Self-inflating. Self-inflating. Retrograde, coronary sinus, cardioplegia, cannula. What is this sport for?
Inflating the balloon.
Self-inflating. Why you require inflating balloon? तुम सांप सीढ़ी का खेल खेल रहे हैं, तू 100 से 0 का नीचे आ गए. Check pressures. So what you attach to this? 200 centimeters, male to male pressure monitoring line. And next question will be, what are the pressure tracings? And cardioplegia is going. After the concluding remarks, we'll ask this question. Till that time, you think. Till that time, no IT allowed to you.
Thank you. At the outset, let me thank our non-stoppable teachers, Dr. Tendolkar, Dr. Prasanna, Dr. Srikrishna. They are still here with us. And we come to a conclusion of this core program. Normally, so he left. Yeah, they left because he has to travel to Vellore. He left. Sir, before I conclude, I would like to request two of the residents to just make few comments, come on stage and tell about the program. How was it? How helpful it is? Normally, I do that. Two of them. Can you come down, please? One from the Lucknow team. Anybody is here?
Siddharth.
Lucknow, yeah.
सांप सीढ़ी का खेल.
You can come down here up.
No.
Who is that? Which place? Which institute? Kindly come down, introduce yourself, and you can tell a few comments, 1 or 2 minutes. What are the program? How else? How would it help? Come, sit here. Come in center. The camera idhar.
The auditorium was so good, I could sleep very well.
Sir, it was a very nice program.
Introduce yourself.
Sir, I am Dr. Siddharth from SGPGI Lucknow. Yeah. Yes, sir. Yes, sir.
Please remember.
Okay. Please go ahead.
Sir, I like the program. The schedule of the sessions was good. The cases were good. They were very informative, and adequate weightage was given to the cases which were very important for the exam. And we have come all the way from Lucknow for this thing. So I would like just a request or a suggestion, maybe that we can have this session biannually, or probably once in North India as well, so that we can attend it.
Sure, we'll look into that. That proposal has come up. We'll definitely look into it. We'll definitely look into this. Come. Different place. That is one thing. We need to talk to all the residents, and the participation is very important. Come. Thank you. Thank you so much.
I'm Sharad from.
On a mic on, please. Yeah. Put the mic on here. Yeah.
I'm Sharad from Yadava Hospital. It was very useful, sir, and teachers were actually more active than we. I agree, sir. It was very good, and we got to learn a lot, which we never didn't know before. The one thing I felt that the case-taking sessions would have been more longer. We would have got to learn more because of time constraint. It was like we were running. Otherwise, it was very good, sir. It was. Thank you so much, sir.
Thank you. I request Dr. Paparao from GKNM Hospital, Coimbatore, who attended the SCORE program regularly and has passed his examination with a gold medal. Paparao, can you come on board, please? Are you there? Yeah.
Yes, sir.
Can you hear us? Yeah. Good evening, Paparao.
Yes, sir. I can hear you, sir.
Yeah, please go ahead.
Good evening, everyone. This is Dr. Paparao from GKNM Hospital. I thank Dr. Hiremath, sir, and IACTS SCORE program for giving me this opportunity to speak in this forum. And I thank my guru, Dr. Chandrasekhar, sir, and all my teachers, Vinay Shukla, sir, and all my almighty and my family for my success. I given my DNB exams in 2022. I secured gold medal in 2022 exam, and IACTS Digi score runner-up in 2021. And how I prepared for my exams? Basically theory and practical. Theory, for pediatrics, I have gone through Mavrodis and some topics in Kirkland, and adults Sebastian, and lung cases and Murjani, and CBB topics, Anil Tendolkar's notes. And coming to the practical exam, the main platform is core. If you follow all the whatever they ask, whatever they teach you, and all, you prepare your good notes and all those, practical will be very smooth walk. Score is very helpful. Before the exams I go, you have seen all the previous years, 2 to 3 years score videos, and they're very helpful for me. Thank you, Hiremath sir, for giving this opportunity.
Thanks. Thank you. It's going up. Yeah. Thank you, Paparao, for coming on board and sharing your thoughts on how SCORE helped you to get through successfully with a gold medal in your practical examinations. Now, apart from this, I would just like to thank my team
Thank you,
members
sir.
who are working tirelessly. I just would like to introduce, I think everybody knows Manpreet, and Gauri sister, our OT scrub nurse out there, and Mukunda, our OT technician, Dr. Madhumati, and our sister Tejaswini, and Shreya, Kavin, and Manya is here from Jaydev, who helped us to see the team members. And also, I would like to thank Sister Usha. They are not there; they are doing some other works. And other Dr. Dharmaraj, Megharaj, they all really helped me in my team to get this done. Dr. Jagannath also stood beside me throughout this program. Once again, we would like to we'll plan to see you all next year. People who are in final years may encourage their juniors to come down for this program. And you also can come down, because learning is never ending. Each time you learn so many things. There are people who have passed out also, they come down for the SCORE programs. And with this concluded remarks, we will have high tea shortly. I request all of you to stand up for the national anthem. Before that, the QR code is there. Kindly scan the QR code so that put it in the groups. That will reveal the feedback form. When the feedback form comes down, we'll share the certificate and the Satyaki notes, whoever gives the feedback form. The feedback form is on session wise. Certain topics I need to cancel because students requested to focus more on the case presentations. So I had to cut down on the lectures. So you can just give your feedback based on that. Because one or two lectures I had to cancel, giving importance to the instruments and all this stuff. I think, can we have the national anthem, please?
You can put the QR code afterwards. Just
तव शुभ नामे जागे, तव शुभ आशीष मागे, गाये तव जय गाथा, जन जय पावत भाग्य विधाता, जय
cheers for Dr. Hiremath.
Thank you, sir. I'd like to thank Dr. Sampath Kumar, who sir was online. Thank you, sir, for joining. We concluded the program. Thank you, sir.
I4 is for measuring pressure, and this is the dressing you get.
So, Shreya, take all the things, sir. IT ready?
And this pressure is according to what? This frequency is according to what? Manya,
We'll have a group photo, Murli. We'll just.
the pump head engagement.
Ella kari sappa.
Disengage. Engage, disengage. Engage, disengage. What should be the value? Maximum. This is the coronary sinus pressure. So how much it should be maximum? 25. 5. Retrograde coronary sinus cardiac here. 25. 25. Okay. So while cardiology are going on,
it goes up and then goes up.
what has happened?
It goes up and then goes up.
Sorry? Dislodge into RA. The person is will tell what? Nothing. Person is knows only resistance. This flow is going or not? Going. Where? RA into venous canal. Understand? So he will not tell anything. It is you who will realize. What will be that value? Bottom value will be what? That is 25. What will be this value?
This value down.
RA pressure on bypass. How is RA on bypass? Say minus something. Don't say 10, 5. Not even 0. Negative.